get paid by them now. But I want you to think about systems. I talked about systems at our very first meeting. So we got this system here that people are living in with regards to addiction and recovery. And you've got an inflow to that system and you've got an outflow to that system. It's like a bathtub. You've got a water faucet coming in and a drain going out. And in the middle, in the bathtub, is all the people who use drugs. Okay. And if we took, I don't know how much money we got in the bank right now, $90 million, I think. We took $90 million and we stuck it all in Narcan. Put all 90 million of it in Narcan. Would that be a good thing? It would be. We'd save a lot of lives, for sure. What's our overall goal? Our overall goal is to shrink the number of people in that bathtub. That's our overall goal. So if we took all 90 million of our dollars and we stuck it in that in Narcan, what's going to happen to our number of people who use drugs? It's actually going to go up. It's not a bad thing. We save lives. It's going to go up. Why is it going to go up? Because you only have a few options after you get reversed. All right. You either get into recovery, okay, or you flip back and forth. The recovery, you're out of the system. Drain drains you out. But if you're flipping back and forth, now you're back in the bathtub. All right. So our goal is to shrink what we call the stock in systems dynamics. That's our goal. So in order to do that, you have to address the inflow, right? Prevention. We're going to have a talk later this morning from Karen on prevention. You have to understand prevention and its role. Its role is to turn off the drain so we don't keep filling up the tub we're trying to drain. That's the deal. Okay, so what can systems dynamics help us with? What systems dynamics does is looks at your entire system and all the things that affect your system and makes really accurate predictions on outcomes based on the money that you invest in certain inflection points. And guys, that's cooking with gasoline right there. Karen went through, whenever we started this, we picked a group of people to work on the grant application itself. And Karen went through all the different things of this, and it was huge. I don't know how long she spent on it. And at the end, she finally came back and had percentages for pots of money that we split this up: prevention, education, treatment. And the words that she said after she did that, she said, it's a guess, or it's a guess. And it is a guess, and it's a good guess, but it's the best one we can have. Systems dynamics will allow us to make a much better guess. And we're going to have a presentation on it later. And there's multiple groups around the country, I think, that do it. And I keep forgetting the train runs right through there. So that's one thing that we're looking at, because if we invest our money, I would like for us to be able to see, are we spending this money wisely? Because if we get an outcome that's not consistent with what systems dynamics presents or predicts, there's really only two reasons for that. One is that we're just wrong, or two, that we've got a barrier somewhere within that system, and now we can go back and try to focus on that. And the reason I tell you this is because in the field of addiction, the one thing that I never see anybody publish are outcomes. I've been doing this for a long time. I never see outcomes. I mean, if I got heart disease and I go to Johnson City Medical Center here and they're going to do angioplasty on me, I'm going to ask the surgeon, what's the chances of me being chest pain free and not having a heart attack in the next 5 years? Because heck, that's all that matters. But when I look at addiction, I don't see that. Call up a treatment center, say, hey, I got a kid here shooting heroin. What are the chances they're not using drugs in 2 years? You're going to get one of two things. You're going to get crickets or a lie. The lie's not an overt lie. They're only going to count the people who come back. They're not going to tell you about the people that they lost. And I'm not mad at those folks. I want to look and see how we get those we lost. I want to take an honest look at where we are in addiction treatment. So I live in a Stockdale paradox. We're going to confront the most brutal facts of our current reality, whatever they might be, while at the same time not losing hope that we're going to prevail in the end, regardless of the difficulties. And I think we can do that. And so with that said, we're going to have Rayford Etheridge to talk to us about systems dynamics. And by the way, those of you that are presenting, you got 20 minutes. All right, we got a strict schedule. I want to stay on it. And I want to get to Lisa and Karen today, because these things are so important for the people who are going to score grants. And so the other presentation is this. Our departments in the state of Tennessee have done great work. We have treatment available in the state of Tennessee. It exists. Finding it is difficult, and it's not difficult because people aren't trying. It's difficult because we haven't had the funding to set up a system that you can get people. Where we can get people where they need to be. So my dream is a 311 number or a 211 number, that you got a website and a phone, and it's on every police car, and you call that number and you don't get a list of 3 places to call, 2 of which don't take your insurance, and the third one, which has got a 3-week waiting period. Guys, this is a public health emergency we're in. I'm not the governor, but if I was, I would declare it. And I'm going to show you why here in just a second. When you call up that number, you need help then. You'll need help in damn 2 weeks. You need help then. We got pharmacies that don't believe in medication, and they'll buy a kid medication, and the kid's going to die this afternoon. This ain't alcohol. You get a hold of fentanyl, you'll die today. Right? I don't care if you believe in medication or not, it keeps people alive. And we can't treat dead people. We got groups that do great work, and I look at my friend Lisa. Lisa and I actually met at a Sunday school class here in Johnson City around this issue. Lisa does great work at Families Free. They have a lot of resources. There are people here that don't know those resources exist, that don't get funneled to the things that they do. And that's what I want a guy named Jerry Koski to talk to you about, how we can use technology to be able to make that happen. Okay, so that's the goal today, and that's going to be my ask. So on the screen, you'll see here, and I'm sorry, guys, I got real emotional last week, and I sent you all a video of where I was. I was in Washington, D.C. There was something there called the Trail of Truth, and it's a bunch of pissed off parents, actually, is what it is. They've lost their kids to drug overdoses. And they have tombstones that they've made for kids all across the United States, and they plant them on the National Mall. And there's thousands of them. And I got out in the middle of it last week. It was right in the middle of Tropical Storm Ophelia. And I was out in the middle of all of these tombstones with these kids on here and their kids. And one of them caught my eye. I'll tell you about it here in just a second. But I was out there in the middle of that looking around, and I just got overwhelmed, and I took a video of it and I sent it to you guys. Guys, this is why we're here. I met people from Maryland, Tennessee, Virginia, North Dakota, South Dakota, California, Nevada, New Mexico, all of the East Coast states. There was a ton of people there from Iowa, and I had no idea Iowa had that big an issue. Right? These folks are from all over the country that came out to honor their children, and there's a tropical storm, and it's raining sideways, and these parents are out there sticking these tombstones in the ground. It was about more than you can take, about more than I can take right now. This one caught my eye. And it caught my eye because he's from Kentucky. And I blocked his name out up there. But a couple of things caught my eye. One, he was born in 1994. My son Heath is in the back of the room. Heath was born in 1994. That's the first thing that caught my eye. And the second thing that caught my eye is all the family members wrote a little phrase to put on their tombstone, like what I hope somebody put something decent on mine. I got some bad stuff. Hope they leave that off. But this one is the one I saw so many times. My baby brother, he wanted to get clean. Her words, not mine. Because people who are struggling with addiction, putting a needle in their arm, don't want to do it. They want to quit. He wanted to get clean. And he did. He's forever 29. He's from Eastern Kentucky. Next slide. So this lady, I saw her coming up the sidewalk, and I wished you could appreciate. You can see the tombstones in the background, so you can kind of get a feel for it. And they didn't have them all out. You guys, I promise you, it's raining sideways. And the wind's blowing so hard you can't see, and up the sidewalk comes this lady. She's got a shirt on underneath her plastic overcovering there that says, "I wear purple in honor of my grandson." She was looking for her grandson's tombstone out there in a damn tropical storm. Next slide. I helped her find it. His name was Brian Smith. And Brian was the ripe old age of 18. And this is happening every day in every state in the United States, and we're standing in the second worst state in the United States in Tennessee. Next. So as I'm roaming around out there, I've got a parka on. I've got my hood's pulled down over my face. I mean, I look, very suspect. And I'm just roaming around, meeting people and talking to them. And somebody grabs me by my right arm and said, "Hey, Dr. Lloyd." Okay, I don't even know how in the world you would have recognized me with all I had on, but we're in Washington, D.C. I certainly wasn't counting on anybody running into me that I knew. And this guy named Doyle Elkins. And it turns out that several years ago, I took care of Doyle's stepson and his wife, Tammy's son. His name's Matthew. I remembered Matthew very well because he was the first diabetic that we got at the treatment facility I was working at. And I had to go to battle with him because they didn't want to take him because he was diabetic. And I was like, well, first of all, I'm an internist, so I think we can handle diabetes. And second of all, what do people with diabetes and have addiction need to do to get help if we don't take it? And guys, I promise you this stuff happens. It happens, and they'll get turned away. Okay. So I met Tammy, and she reminded me of Matthew. I remembered him immediately because of the diabetes and the battle that I had to go through to get him there. And Tammy is the therapist herself. And she's crying because the only reason that she would have been there is why? Because his tombstone is in that graveyard. And she said, Dr. Lloyd, I wished I knew now what I wished I knew then what I know now. And so she lost Matthew to an overdose. She was going to be here with us today. She's from Murfreesboro. But I told her she would send me the pictures. I would tell the story to the best of my ability. But I want her to come because she told me about this group of parents, and I saw them meeting each other. There's a group of parents in the United States that have met each other by social media, and it's a big group. And what they do is they help people from other states that need to find treatment. It's unbelievable. And they've never even met each other. Some of them hadn't met until we were in DC together. And it's this huge network, and that's a great thing. But guys, it's a workaround. It's a workaround. It's damn luck to know one of these people to get them to help you. I'm talking about taking the luck out of it, and that's why I want Jared Koski to show you what I'm talking about. And it's why I think we need a request for proposal from groups that can do that, and let's automate this system and give people the help they need in a timely manner. Next slide. This is a picture that she sent me. I take it it's a special one or she wouldn't have sent it, but that's Matthew. Looks just like any other 20-something-year-old that I see running around. And then the last one, unfortunately, Matthew's forever 24. 24, 18, 19, 26, 30, right? She's got 50 years of life. Next slide. So where do we stand in Tennessee today? So the CDC recently released data. It was published in about every major newspaper in the United States, and actually on the Tennessee and in Nashville, it was on page 1. It looked at drug overdose deaths in metro areas across the country. Tennessee has 2 in the top 8. Shelby County is number 8. Davidson County is number 2. Memphis and Nashville. Now, the weird thing about that is neither one of those 2 are the worst in the state of Tennessee. What's the worst place in the state of Tennessee? Knox County. Knox County didn't meet the criteria for a metro area. Actually, we would have had 3 up there if Knox County had a few more people there. Tennessee's the 2nd worst state in the United States. The only state ahead of us is West Virginia. And I love people in West Virginia, but you don't want to be on the same list as West Virginia, right? Because that's where they are. West Virginia, Alabama, right? We're right in the middle of that. So I want to touch briefly on pain pills because we talk so much about heroin and fentanyl, and as we should, because it's killing kids and it's ripping families apart. Guys, pain pills are still bad in Tennessee. They have not gone away. No matter how much the CDC wants to change their guidelines, and no matter how much industry is out there barking that everything's secondary to fentanyl and heroin now, because it is absolutely not. It is absolutely not in our state. Opioid dispensing rate, and this is pain pills, in the United States is now at 43.3 pills per 100 people. That's the lowest it's been since we started measuring it nationwide. What about Tennessee? Tennessee's opioid dispensing rate is 68.5 per 100 people. We are still in the really bad category. What about Washington County? I picked Washington County because that's where we're standing. Washington County's dispensing rate is 140 pills per 100 people compared to a national average of 43. And I looked at the top 10 worst counties in Tennessee, and 6 of them are in East Tennessee. Okay, 15 counties in Tennessee are 100% higher than the national average. Not 100% of the national average, a whole 100% higher. So it's more than double, 15 of our counties. We still have a problem with opioid pain medication, guys. It has not gone away. And so I tell you that because that's the faucet. But that's the faucet that's filling up the tub, that's increasing the number of people that we got that are struggling. And our job is to decrease that. Next slide. So all of you in front of you have a proposal. The proposal was put together by Meharry Medical College, and I've got a representative here today, Dr. Lyle Cooper. If you don't mind outing yourself, he's in the audience. I asked for it. I want to flood the state with Narcan. If you look at where we are today, October 2nd, 2023, it's on the signs. The money that we're going to allocate at our next meeting, hopefully, as we get this grant money in, and that's a really good thing. Realistically, it's not going to be in our community until July 1st of 2024. That's when it's going to get there. That's how many people are going to die in Tennessee in the interim. 2,808, and that's if it doesn't go up, because it's shown no signs of going down, guys. It's still going up today. And so in front of you, you have a proposal there. We need $7.5 million, and I want $7.5 million today. Meharry Medical College is a nonprofit. It is affiliated with the historically Black College and University in Nashville and TSU. I've known Lyle, I've known Sam McMaster, the people who work there, for almost as long as I've known Rob Pack. They have a network that they have put together over the years to distribute, I'm sorry, we're struggling with that, things, right? Medications, resources, all across the state of Tennessee. We want to put Narcan in the hands of people who are around people who use drugs, not in the trunk of somebody's car. All right, and we want no strings attached to it. And we need a network that's able to do that. And one of the things I love, Tennessee's a Second Amendment state, right? And so this is what we came up with. We're a carry state, guys. We carry Narcan. That's what we're going to carry. We're going to try to save lives. We're going to try to keep these people alive until we can get the money in our community to help. And I want to take action today. I don't want to wait 2 months. I don't want to put it off. I want it today. We can have it. We can have it out in 4 weeks. 4 weeks a day. If we appropriate this money for it, we buy 150,000 units of Narcan. We're working with another nonprofit in the Nashville area. When I say we, not me, I told them what we needed. They went out and did it. I'd have never got it done. We're working with a place called Fund Recovery. Fund Recovery is a nonprofit. Fund Recovery has access to Pro Football Hall of Famers and country music stars. And they have agreed to use their resources to make PSAs to air all across the state of Tennessee about carrying Narcan. One of the most famous, well, I guess the most famous musician in Nashville right now is a guy named Jelly Roll. And Jelly Roll is in recovery. And Jelly Roll is one of the people that we're going to get to help us. And these folks have those connections. And not only that, if you look at the proposal, it's not just about Narcanning, it's about going ahead and finding resources for them to get help with their addiction. This is a stopgap measure like Congress did the other day. It's what we're doing right now. And if I'll leave you guys to read it yourself. If you have any questions, you can ask me about it. But I wanted to lay the background for you, why I think it's necessary and why I think we need to take action. Because I haven't seen another state jump out and take action immediately. And I think it needs to be us. We got the second worst problem. We got the people in this room that care about this issue.
For the Opioid Abatement Council members who are attending virtually, I have taken a picture of the handout and I am emailing it to you right now.
So those of you that are attending virtually, Dr. Vanterpool and Dr. Jackson and Dr. Moore and Armando.
Yes.
I'm not springing this on you guys. Ideally, I'd like to send this out a month ago and called you and talked about it, but that violates the sunshine laws. And so you can't do that. So it's out here for everybody to see as we discuss it. So it is not an intentional blindside. I would never do that.
No problem.
And I don't know if anybody work here. Can I have some water?
Oh.
Okay.
Sam, are there any legal issues with this in that we've not done an RFP or?
Need to go through the proposal, but what guidelines have been, I wasn't at the last meeting, but as far as would this be covered under the community grant process? And then as far as what guidelines were passed by the council for the community grant process?
I think it's a great proposal. I just want to be sure we don't stub our toe on our first major allocation. So have you had a chance to review this or think about it in those terms, or?
I haven't. I'm happy to look at it, and if we need to have an internal meeting, legal meeting to discuss, we can do that off the record.
Ideally, you like everything to go through a grant process, and I get that. Our grant process is going to take a while, and I realize, generally, we don't want to stub our toe. I understand that completely. Believe me, I didn't because I know what the potential is here, but I think that the juice is certainly worth the squeeze. So we have the ability, the council, is to allocate money as we see fit to address the opioid crisis in the state of Tennessee. We don't, our legislature didn't give us a set of rules. Matter of fact, it didn't even tell us we had to do it by grant process. It outlined this council, and the council decided on what our process would be.
I have
Council
a
member,
question.
Dr. Vanderpool?
Yes, I am looking at this proposal, and while I think it is very, has a lot of merit, I have some questions about the monitoring and the reporting back to us that is not listed in this one-page proposal. How do we know, are they requesting the allocation up front? Are they requesting 50% and then see how they do and then get the other 50%? Like, I think that I would be more comfortable if I had more details as to the mechanism by which this would be executed. While it is an admirable program, we want to make sure that if we're going to send $7.5 million to an organization that has all of the historical and likely all the capabilities to handle it, we want to make sure that, just like you mentioned in your opening, that we're able to monitor outcomes effectively.
So, Dr. Vanderpool, I've got Lyle Cooper in the room, which is exactly why I asked him to drive up from Nashville. So Lyle, do you want to address that?
Sure. I would say in terms of how the funding is allotted, we're open to whatever makes the council more comfortable. But I would also say, in terms of monitoring, one of the beautiful things about this is that the company that we're working with has real-time monitoring of the distribution of Narcan. So we can, or naloxone. So we'll know in real time where all of those units are going, and we can report on it at any given time. That's a part of the way that we'll distribute it, is that it's automated so that we get real-time data on this zip code got this many units of Narcan. This is what they started with. We need to top them up right now. So if the state ever wanted to call us and say, where are we at today? We could just say, this is what we've done so far. So I think the monitoring in that sense is really, really tight and accessible at any given time.
So are you telling me that if we ask you to report to us monthly on where this stuff has gone and where you stand in the allocation, you could do that?
Absolutely.
Armando has a question.
I'm sorry, Sheriff. I'm sorry, not
Yes.
Sheriff anymore. Armando?
Yes, so my understanding of it, based on reading through that, each community will be required to develop a plan of how they're going to distribute the naloxone. Now, will each community will they be delivered units, or they will actually be given funding to make the purchases?
Lyle?
They'll be given units, and we have consultants that are going to work with each county across the state to help develop those plans. So the way that we've divided this up is to use the same formulation that you guys use to allot money to the different counties across the state. So we'll start with that allocation, and then going back to that monitoring system where they're automatically reordered. As we start to identify places that are running through Narcan faster, that'll be something that we'll also be able to address.
Thank you.
Another question, how are you going to be able to tell that the Narcan has been used?
Every time a unit goes out, there's just, the only data that they request is the zip code and what formulation of Narcan it is. So when that goes in, it's put into a computer, goes back to Harbor Path, the distributor, and they know at that moment that it's gone out of there. So it's not a direct knowledge of whether or not it was used, but it is a direct knowledge of whether or not it was distributed.
I'm sorry, go ahead, Armando.
So one thing that we did as a department was each time we used a unit, regardless of for our patrol division, we had a specific officer that was assigned to keep up with and report every unit that was used, date and when. So I think it would be a good policy to have in place that, any of these units that are dispersed, that they have a similar policy in place that they report back each time they have a use. That way you're knowing where these things are being used and not just being put on a shelf and left somewhere. And then once we begin to run low, they would see that we were actually using these units, and they would replenish our units for us.
As far as being put on a shelf, the distribution would handle that. It's the fact that they can track that, and so we would know it had been distributed. And when you're looking at first responders, Armando, you're exactly right. That's an easy thing to do. We know it's been deployed by an officer or an EMT. But we're also talking about putting units in hands of people who use drugs, because people who use drugs are around other people who use drugs. And I don't think that it's going to be very easy for us to get that. I can just tell you my experience in several of the homeless encampments in Nashville is that if you go into these encampments, they usually 1 or 2 or 3 people in there that are pretty versed on Narcan. And everybody in the camp knows that. And so when somebody overdoses, they run to that person and then they deploy the Narcan. And so I think those numbers are going to be a little bit tough for us to get, but we can for sure do it with first responders, of course, emergency departments, schools, anybody else that we deploy to. But one of the things I want us to really pay particular attention to is that you can have these ideas in our head about being able to track this or that. We're talking about being able to get these units into the hands of people who are going to be around people who are using drugs. Okay. And then we got to be realistic about that. And we may not be able to get that data. Where we will get that data, we should be able to see our overdose numbers, our overdose death numbers come down. And really the next step in the homeless encampments, because I didn't know or understand this. I went there on a Thursday morning the last time we went. On Wednesday night, they had 4 overdoses in the encampment just in one night. 3 of them, Narcan was deployed. The person was rescued. None of those 3 went to the hospital, and the other one died. And I asked the lady there who everybody said was their go-to for helping them with Narcan, and she says they have about 10 to 12 overdoses per week. So that's kind of what we're looking at, and that's a medium-sized homeless encampment in Davidson County.
Clay has a question.
Dr. Jackson?
Mr. Chairman, I'm happy to debate the merits of the proposal, but I think that's premature. I think we first need to settle the issue of whether this is something we can do and want to do in terms of an emergency allocation or an RFP. It's my understanding, and I'm not the legal mind in the room, but it's my understanding that our remit by the state legislature and by the appointment of the governor is to get money to help the problem. It was left to us to determine how to do that. We have established a standard process to do that. I do not see that we have a legal impediment to providing emergency allocations. I do see, and again, I'd like for our legal mind to give an opinion about that, but I don't see that we have an impediment to dual pathways of funding, a usual pathway of grant proposals, but then on an occasional basis or a one-time basis, making an emergency allocation or 2 at the beginning of this process to keep people alive so that we can then treat them at a later date when our funding finally trickles down. However, if we do this, 7.5 million today, whatever SAS wants, as a council, are we willing to take the heat from somebody who doesn't get funded 6 months from now and they say, well, we did the grant process, we did everything you said, we scored this stupid score, but you didn't give us any money. And you handed Meharry 7.5 million, or you handed SAS $2 or whatever we allocate to SAS. First of all, do we have the legal remit? It is my opinion that we do, but I'm not the highest legal authority in the meeting. Number 2, if this is legal, are we willing to take the heat that says, yes, these programs did not go through the usual process of grant funding, but there was an emergency. The council decided to allocate outside of grant process. Will we do this again? Because I think people will ask that question. So I think I've raised enough issues. I'd like to toss the hacky sack in the air and have some people talk about that.
Lisa has a question. Do you want to go to Sam or?
Yeah, whoever, Lisa, go ahead.
No, I'll follow Sam. Go ahead, Sam.
Well, looking at the statutes, what we have to go off of, right? So we have councils to create a certification process to verify funds for programs that they approve. What the council is to approve are programs for opioid abatement and remediation purposes. It goes on to talk about creating a certification process for counties applying for funds. But to Dr. Lloyd's point, there's no, and to Clay Jackson's point, there's no specific process for what Dr. Lloyd is is proposing, other than that the council has created their own RFP process. And if they choose to do that outside of this process, I would leave that up to the council. But I'm happy, again, to go off the record, have a discussion, include the Attorney General's office, who's also on the call if we need to include them.
Yeah, do we have a representative from the AG's office with us online?
I do believe Andrew and Michael are on. You guys can turn on your camera and your microphone if you'd like to.
Yeah, this is Mike Stahl here. I agree with Sam. I think it's probably worth a discussion. Maybe not right now because it's a legal question. So I think it deserves some attention, but I'm happy to get with Sam and whoever else and figure out the right answer.
Hi, it's Andrew Coulomb. Completely agree with Mike on that.
Mr. Chairman?
Yes.
Might I propose then that we direct yourself, Mary, and the Attorney General's office and Sam to have a meeting offline to determine the legality of this, and then we move forward with discussing the merits of the program. Also with the SAS program, it's the same issue because both of those potential funding sources fall in the same category of emergency funding. We could move forward with discussing the merits of the program. I would propose that the council would vote up or down on both of these proposed RFPs outside the grant process. If the Attorney General's office and you guys in your meeting determine that we have a legal path forward, my proposal is that those, and if the council votes them up today, then we would fund within the next 2 weeks. You guys can have that meeting that we would then fund. If we vote down, obviously it's a moot point. If we vote up and the AG's office votes down, then I would say that we just have Meharry and SAS present a proposal and we score those things, but that we get, those are the first ones that we score in order that we can get this money out sooner rather than later. If we need to go through our usual process, we can do it. We don't have to wait to July 2024 to get this out.
Thanks, Dr. Jackson. I'm going to call on somebody because I've heard him run a couple of times. I'm anxious to see what he thinks. Shane, what do you got in your mind?
I think this is a dangerous precedent. If we go around the process, there's been all those months creating a procedure, protocol to review, to vet, take a look at these proposals. And then our first let is an end run. We got some answers to give at that point. And I'm just not prepared to give. I think we've got, it's a very noble proposal, no question about it. We need to be careful. That's a lot of money and we don't know much about it other than what we've heard here today. So I would have to vote no today. Not that you're calling for a vote, but and it's not about the proposal, it's about the process.
Lisa.
Yeah, thank you. And I would agree with Judge Sexton as well. And all that you said, it's not about the proposal, but I would go back to looking at the percentages that were put together by the team and how much funding is going to go in to each area, whether it's treatment, whether it's prevention, whether it's other areas. And this is a very, very large amount of money. And it's a presentation, it's very well laid out, but I would agree with Judge Sexton, and my vote would be no to go around the process that's been laid out so many times.
Let me add one other thing. If we're going to do this, let's create a real path. Let's not do what we did with the buckets and all that with this. If there's going to be a second route for emergencies, we need to discuss that and come up with a mechanism to do that where it's faster track and we don't get into the bureaucracy, for lack of a better word, on the grants. Do we really think that money's not going out the door until June of next year? Because that's surprising to me. I thought we would have going out now or
talk about the time it actually makes a difference. If you think about things that we'll fund, things that we fund that are expansions to existing programs, hopefully that'll be sooner than that, Shane. So that's a good point. But things that have to be built from the ground up, it'll be later than that as well. And I appreciate you saying that. I just didn't have the opportunity to do that, right? I mean, with the sunshine rules, I can't call you all individually and say, hey, let's talk about this. It's got to be done here. So I'm fine with that. I wanted to throw it out there and let's figure out a process for it. I'm not, I will always, I guess, succumb to the will of the group because I think your minds combined are better than any one of us alone. But I don't want to, put this off and kick the can down the road to December. And I want to make a decision on one way or the other and see if we can go forward.
I think Deputy Commissioner Yancey and then Ken Moore.
Okay.
I was just going to say, I think the council's interest to expand access to naloxone makes a lot of sense. I was just curious though, and Dr. Cooper may be able to speak to this. I think about the state's 46 prevention coalitions that have these regional overdose prevention specialists in place that have been there for the past 5-6 years or so. And since 2017 have distributed 500,000 units of Narcan. Would there be coordination, collaboration between the RISE project and the prevention coalitions and those regional overdose prevention specialists? I know like at Metro Drug Coalition, they partner with the state to distribute naloxone. Just so trying to think through how these things would be connected and complementary of each other.
Sure. Yes, for certain. We definitely want to involve the coalitions. We also want to involve we want to involve business folks. We want to involve people in local government. We want to involve harm reduction organizations, treatment centers, police. And I think one of the keys, I totally agree with you. I think the ropes have been absolutely fantastic. I think this would be more of a complement to it. I think one of the things that, in the proposal that we really want to do is I know a lot about how to get things done in Davidson County, but I know enough to know that I don't know how to get things done in every single county in this state. So what our initial plan is to develop an individualized plan for each county. So, and that would include the coalitions, that would include, all the other parties that I've mentioned. But that's a big chunk of what we want to do. Like that's most of our personnel actually is like sitting down with the people. If it's not a single county, if there's a few smaller counties that are together, it makes sense like that. But otherwise, it's going to be going to every single spot and developing a plan that works for them.
Thanks. Mayor?
Well, good morning. And, I would advocate that we continue to follow our process, but I think this raises a good question that we need to create some type of mechanism or process for these emergency requests.
Okay, thanks, Mayor. So I think I've heard the will of the group, and that's what we shall do. So the first order of business will be looking at it from the legal standpoint. And I really don't want to do this at Christmas time. So, I'd like it to be in the next 2 weeks if that's at all possible. And then deciding on the legality of it, and then involving people in the group that want to be a part of it about, do we want to develop a pathway for things like this? Because there isn't anything nefarious here. Narcan's not going to solve a problem. It's going to keep people alive and, help us to, I can't treat dead people. I say it everywhere I go. So there's nothing nefarious about here, and it's not about choking anybody out. And it's a stopgap until we get money in our community, and it's just for a limited period of time. So that's the thought process behind it. And I'm sorry to drop it in your lap like that, like I'm dropping everything in there, but under the rules, I don't see any other way to do it other than discuss it in open meetings. So that's what we'll do. So if we can put that together, Mary, and I think I've heard the will of the group.
And Clay Jackson has.
Go ahead, Dr. Jackson.
Question's actually for you, Mary. So I propose that initially that we could check the legality and maybe vote up or down on the proposal today. Heard from others that circumventing the process is not preferred. Let me ask you this, Mary. If we go with the usual process, what if the RISE group wrote a proposal on our grant app? How quickly could we get that done?
The system is ready. What we don't have are staff. And the deputy director starts on October 16th, and we are interviewing for the grants analyst next week or the week after that. So while the system is there, we could, it's set up to score. It is the scorers that we are missing right now. So as soon as they get on board, we can score the application. So talking that through, maybe the first week of November would be
But
when we.
You're one of the scorers, right?
I am not a scorer.
Okay.
The scorers will be Sage West, who I'll introduce here in a minute, who's going to be the new deputy director, the 2 grants analysts, and then the Opioid Abatement Council members.
So we have 15 council members, and then we have Mr. West. So I mean, don't we have some people that can score this? I mean, if the application came in next Monday, don't we have people that could score it now?
And Ms. West won't be on board until October 16th. So, I mean, unless you want it to be scored by just council members, we can do that.
No, I think I think what we've heard is we created a process. Speeding it up is one thing, but I think following it is the core will of the group that I'm hearing. So I'm just wondering, could we realistically, this proposal is already put on paper. If the RISE group could put that in our system, and Ms. West, I apologize for inadvertently misgendering her. If she's on for October 16th, I mean, we could conceivably score this thing the 3rd week of October.
That's true. That's true.
I want to hear from some other, I'm not the chair. I'm just interested in the opinions. I'm interested in the opinions of others, if they would be comfortable with that in terms of a sort of a fast track approach, because it would still be scored in the standard way.
Mr. Chairman, this is an example of how we're going to learn how to do this,
Right.
because we're talking about accelerated requests as opposed to people who are just following the process. And we have to be careful about taking a preferential treatment to one over another.
Right.
And that's going to get us in a lack of credibility that will end up happening. It looked like a frat house kind of stuff. And we don't want to do that. We just simply don't want to allow someone to jump a line in front of people who are just as deserving, have just as noble proposals. But we think this is an emergency. And that's why we need to talk about us doing a reach down and getting some of these issues dealt with like this one you're talking about. If we think that something is that dire, then we ought to have the discretion to go get it. And, but we need to have a process in place for that.
Thanks, Jane. Lisa.
And in regard to when money can go out into the community for various initiatives funded under the Abatement Council umbrella, is there a barrier of a time limit as to when the mayors and the county commissions can appropriate the funds that have already came to them for projects such as this, if they so choose?
Yeah, they have the money and they can allocate and spend it now.
So that could happen now.
That's right.
So
And,
that
I mean,
doesn't hold this up.
Right. Tim Fournette.
I'm sorry, Dr. Fournette.
Yeah, I agree that we need to make sure we don't give preferential treatment, because and if someone else asks for it, why aren't they getting it? It make us look really odd that we are giving preferential treatment, and I wouldn't want to agree with that.
All right, thanks, Dr. Fournette. So I don't think we need a vote. I've done a quick tally in my head and I don't vote. So I don't think that's necessary. We just need to try to find a path forward. Sharon?
I just have a question. If there is someone that has currently put in an application and we have it in our queue, and just say they're Foundation A.
Mm-hmm.
If Foundation A has put in an application at this point, what is the average timeline that application A, their company, would be on right now?
Well, we're not planning to score any applications until the close date of October 16th. And then the time frame that we're looking at, we talked about, I kind of went over this at the last meeting. It's going to be about 3 months to score all the applications. We're looking at around 400, 450 applications. So 3 months to score. then we will have to have a meeting or two, we'll see, to approve the applications. And then we'll need to write the contracts for those I mean, it should be one contract, hopefully one contract with the scope being the application attached to it. So it's going to be at least 6 months for us to score, approve, get the contracts. Then there is, you know, pushing it through Edison to pay to make sure that those payments occur to the agencies. Was that helpful? That answered your question?
Yes, I just wanted the timeline for someone else to compare to this.
Right. Tommy Farmer has joined the meeting.
Hey, Tommy, it's good to have you. Thanks for joining us. All right, so we've got a plan to go forward with how to address this, and then we have the ability to call a meeting. Really, I have the ability to call a meeting anytime that we need to. So if we get something put together that I think needs to happen before our next meeting, then we'll make that call after we talk to the Sam and the folks from the AG's office. And guys, I appreciate your time and attention to that. And I would never just drop that in your lap. I wish there was another way to do it, but you know, I appreciate what you said, Shane. My intention is never to turn anything into a frat house. My intention is to keep people from dying. And that's the whole reason I brought it here. So we have who's up next? So Jared Koski is going to join us by video. Jared is going to talk about the idea of a statewide bed board. And the reason I really like this idea and the things that folks out there can do, and this would be the RFP that I was talking about, is to take advantage of our existing resources. Like Matt just said, we've got ropes all across the state to do a great job. What this would do would be to complement the work done by the ropes. What a statewide bed board does is to take all these places that we have across the state, from recovery support services to housing, to all levels of treatment, outpatient programs, and show the availability and spots in each of those in real time, so that whenever somebody calls, we know what insurance they have, what insurance is taken or not taken by the facility that we're getting ready to do a warm handoff with. So that's the idea behind it, is to maximize what we're doing with our current resources. So that's where this came from. And Jared, are you ready?
Jared
Hi,
is in the.
Hey, Jared, all right, go ahead.
Can everyone hear me?
Yes.
Okay. So hi, my name is Jared Koski. I'm Chief Technology Officer and co-founder of AddictionAbatement.org. Originally, I started as providing data analytics for expert witness testimony during the opioid trials. From there, I went on to the National Substance Use Disorder Strategic Advisory Panel, and now to AddictionAbatement.org. I have a few other people on here. If you'd like to introduce yourself.
Sure. I am Dr. Jeff Nagy. I've known Jared since, oh goodness, Jared, 2008. I'll turn my camera on. Jared and I met in the military, and we both ended up in data analytics. I'm a data scientist. I did a doctoral fellowship at Stanford Psychiatric and Behavioral Health Department with Dr. Tricia Suppies, working on SMI patients, also looking at addiction. My wheelhouse is primarily data science. I've written some algorithms for the VA on getting better care for our veterans, as well as working with Dr. Nadine Burke-Harris out of California, doing work on ACEs, which, as you all know, is a massive contributing factor to addiction. So I'm just excited to be a part of this, and looking forward to working with you.
All right, I'll go next. I'm Garrett McCormick. It's nice to meet everyone. I am a principal data and software engineer that's been working with Jared over the past several months to help build out the technology foundation for this project.
Thanks, Garrett. And last but not least, my name is Dr. Katie Adastra. My background is in biology and biochem, which is complemented over the last 2 decades of collaborating with both private and public entities to develop innovative software tools for strategic problem solving. Today, as Dr. Lloyd shared, this group will be showcasing a dashboard, an opioid command center, if you will, This dashboard enables data-driven decision-making and tracking of funds throughout the state of Tennessee. This will give you all, including the public, visibility into many of the metrics you'd like to see, as well as real-time feedback of outcomes that matter to both the treatment centers and to the patients. Something like this would be a source of information for the entire state of Tennessee and would allow you guys to triage resources in real time to enable better care decisions. And as Dr. Lloyd said in his introduction today, get the help that is right for you to save lives. The agenda for today includes showing some of the mock-ups of what this dashboard could look like, as well as playing a recorded demo to showcase some of the features. The ultimate goal of this strategic initiative is to give you transparency and visibility into your data so that this can inform you on where the funds are most needed and most effective. Before we jump into the show and tell portion of the presentation though, my colleague, Dr. Nagy, is going to share a little bit more on the art of the possible for a dashboard command center like this. Dr. Nagy?
Katie. Yes. So just a kind of a brief flyover, and it sounds like you all are pretty well already in the muck and the mire of this pernicious epidemic across the United States, and not only within Tennessee, but everywhere you turn, it's touching families. So again, we're just happy to be able to share with this. But here's kind of my thoughts on this as a data scientist. The data exists for us to have this really robust dashboard, surveillance dashboard, right? Where we're looking at mapping of not only hotspots of overdoses, but hospitalizations. We're looking at beds available for patients. We're looking at housing. So, you know, reducing deaths, that's obviously the ultimate goal. But ultimately, we want to get treatment. So folks need to get in and they need to get some treatment. This is a very unique epidemic in that from a neuroscience perspective, targeting the reward centers of our brain is really difficult to kind of walk back. But from my experience working in public health and epidemiology and in psychiatry, data and data science is the solution. Partnering with different groups and different institutions, which we have that capability, working with research institutions, hospitals, and then local groups and government organizations. So one of the things that interests me about this is building a predictive algorithm. So now you're not responding, you're not reacting, you're actually preparing and planning. That is possible. We're playing with some data now to where I think we can actually predict a next overdose based on the number of Narcan administrations and hospitalizations. Obviously, getting some of that utilization data is going to be important, and prying that away from folks is one of the challenges that each of us have in this field. But there is ways to incentivize that, and I know that we'd be really excited to partner with you on doing that. So that's kind of like an overview. Again, just appreciate being here and hearing some of the feedback that you all have, and we're just excited to move forward.
Okay, and we'll go ahead and go over some of the demo now. We'll go over it pretty quickly so we can answer some questions at the end. I know this is it'll be somewhat dense, so it's just kind of a brief overview, but we'd be happy to speak to anybody after this.
All right, you can go in and share your screen.
Okay. Garrett, did you share?
Yeah. Sorry, it's being a little slow right now.
Okay, well, he's loading it up. I'll tell you the problems that we've seen so far is it's difficult to quantify the extent of the opioid epidemic at any given time or area. Normally, you have to wait for reports to come out and to see exactly how many non-fatal overdoses there were, fatal overdoses, hospital utilization, and first responder utilization. as well as treatment center utilization. Outcomes of treatments are not always available in a timely manner, and at times are nearly non-existent. Most program evaluations take approximately 2 years to complete. Treatment is difficult to find and usually takes many calls and tries. And for most addicts, that's difficult. And our goal is to make treatment as easy to find as the drug of choice. So we aim to remedy these, this and many more issues. Our goal is to get near real-time reporting on non-fatal overdoses, first responder and hospital utilization, treatment facility utilization, provide feedback on treatment outcomes at any given time. So what we have here is the dashboard overview. This would be your homepage whenever you log in. This page will give you a snapshot of what's going on in the state or county. It's completely customizable to what you want, but the default here shows your overdose EMS calls. So that's your EMS utilization and how many overdose EMS calls received the past week. Fatal overdoses, estimated EMS costs, non-fatal overdoses. Below that would be overdoses over time. So you'd be able to take a look and see if overdoses are trending up or down. Overdose by gender, overdose by drug type, and overdose by race. With this, you'd be able to customize your overview to whatever you want to see. So if you want to see how many treatment beds are open at any given time, you could place that on there. Basically, whatever is important to you to see. You can select on a different county. You can go through, you can look at different counties, different time periods. If you want to see how overdoses are trending in the past year, you can look at that. We'll go ahead and go to the map view.
Oh, did that change for you, Jared? Or did it?
No, it didn't.
Okay, one sec. Let me share the. Is that better?
Yes. All right, so this is the map view. What you're seeing here is you have different overlays on this, and you have fatal overdoses, non-fatal overdoses, treatment centers, treatment coverages, and also treatment deserts. This is showing fatal and non-fatal overdoses for the past week of Davidson County. This is all dummy data, by the way. So once we actually have the real data, you'd be able to see it. And the shaded areas, those are treatment deserts. So those are without outside of a given range of a treatment center. And so what you're seeing here is you'd be able to customize this to a different county, be able to go last month, last year, see how many non-fatal and fatal overdoses occur within treatment deserts. What that allows you to do is push out community-based outreach programs into those areas and also plan for any new treatment facilities being built, so that you're not overlaying them in areas that are not in need. This shows the areas that are most in need of funding and also most in need of intervention. Next slide. I thought there was another. Can you go back to the map, please? Okay. If you want to switch off of treatment centers and treatment coverages, then you'd be able to just click those buttons down below under treatment centers, treatment coverages, and it would show a different map. So you'd be able to see where treatment centers are and also what the coverages of those areas are. Once we have more data, say treatment centers that have openings, we'd be able to display that as well, and also treatment center utilization. So I'd be able to see which areas are being utilized the most, to be able to pump more funding into those areas into those treatment centers that need it. So if you see an area that is high utilization, that needs more funding in order to expand, you'd be able to do that as well. So this would actually give you a very good planning tool moving forward. Okay, if we could move on to funding. All right, so the funding, now this can help with many different things. So we have this separated in harm reduction, treatment, prevention, recovery, mental wellness, workplace and employment, and total funding. Every county is going to be trying different experiments on what works. By being able to take a look at this in near real time, we'll be able to see what works and what doesn't for different demographics and different socioeconomic areas, as well as rural and urban. So looking at this, you can see what combinations work for different areas to create your own best practices throughout the state and be able to share that throughout. So if we go to key metrics, I believe is the next slide, we can see the total incident rate and program utilization. So if we look at total incident rate, if it's rising or declining, and those would be based off of hospital utilization, first responder calls to SUD, treatment center utilization, as well as non-fatal and fatal overdoses. You'd be able to see which way they're trending, as well as program utilization, how many funds have been granted, how many funds have been utilized. So this would give you the ability to look at outcomes of different programs, as well as predict the outcomes moving forward. Okay, go ahead and move on to treatment. Oh, and you can also request funding from here. So the funding, you request funding through here, and then when I go to the council. All right, so this is the find treatment. So this is kind of the 311 that Dr. Lloyd was speaking about. So with this, you'd be able to type in an address, a zip code, a city, define how many miles you want, what kind of care type you want, as far as it's inpatient, outpatient, and a treatment, as far if you want Suboxone, methadone, buprenorphine, or no narcotics used. You'd be able to search for those. With these, would put up pins, let you know what's within that radius. And then if you actually clicked on the pin or the question mark next to it, then it would pull up the treatment center information. They'll give you the address, contact information, the treatments available, as well as insurance accepted. And once we get data in, as far as beds opening, we'll be able to show if there's beds actually open in that facility or not. And then this would be something that also would be used with a 311 in order for them to do warm transfers over to those facilities. The goal is that when somebody is brave enough to say that they have an issue and they have a problem and they need to find treatment, that they are not going through a phone book or Google and calling 5 different treatment centers to only find out that there's no treatment available, that there's no beds available, that they have to wait 3 months. They'd be able to see it right away and see what treatment centers have openings so that they can get in and get the help that they need. The goal is to make treatment centers as available as, their drug of choice. Yes, Stephanie?
I was going to just raise my hand. Are you finished with your presentation? I have some questions for you.
Not quite yet. We just have a couple
Okay,
more.
no problem. Then I'm just going to leave my hand up, and then whenever you're done, I'll ask the question. Thank
Okay,
you.
great. Okay, next slide. Okay, this is the report page. So any information that's on the dashboard, whenever it gets pulled in to the dashboard, you can create, the dashboard can be customizable to whatever you want, and you can create a report from there. So we understand that, somebody that, you might be looking at different metrics to create reports. So this allows you to customize whatever report you want to look at and see that. Okay, and alerts. So this is an alert page. You can create alerts to alert anyone to any metric that you want to see. So say you see a 10% increase in non-fatal overdoses in a given area, you can create alert to go out to those community-based outreach programs or anyone else to receive that alert either by email or text. I believe the next slide is just a quick demo of showing that. Yeah, and so this would be able to create that alert name, select the metric that you want, the geography of where you want it, and then the people you want to send it to. And I believe we have a quick 2-minute video that just clicks through the demo. When we originally were coming on here, we weren't sure if the screen share would work or not. Garrett, would you like to go ahead and play it?
Are you guys seeing that all right?
Yep.
Yes.
Is there supposed to be sound?
No, there's no sound. For this, we just want to show the functionality of it, and how quickly it can load, it can display information, and just kind of give an idea that it is clickable through. You can see, go through it, and kind of just have a better understanding than the slides.
Jared, for the sake of time, do we want to go ahead and allow questions while this is playing in the background?
Sure.
So, excuse me, I've taken the room off of mute, and I'm going to ask folks who in the virtual world to leave this microphone unmuted, and that way the council members can ask questions. So I think Stephanie Vanterpool's up first.
All right, thanks, guys. I appreciate your presentation. I have a few questions. First, the data that you have in the dashboard is only going to be as good as the data you receive. So what is the process for getting the accurate and real-time data from all of these various institutions, organizations, small and large, beds, et cetera?
Right. So that would take partnerships with the state, as far as the Opioid Commission, Health and Human Services, to get this data and get it in a reliable manner. I know other states such as West Virginia has already mandated that first responders and hospital utilization be reported within 24 hours of an SUD treatment or a call goes out. And with that information, we'd be able to update the dashboard every 24 hours. They're doing that for a year to show value in it, then moving forward to near real time.
Got you. And then my second question is, you mentioned something about requesting a funding request directly from this portal. Can you elaborate on that? What type of funding request are we talking about?
So for that, it was, if you wanted to use us to funnel any RFP requests to go through to the Opioid Commission, we'd be able to do that. Then once it's approved, then it would flow and would have visibility into that to be able to track on the reports.
Yeah.
Okay.
Dr. Vanderpool, that was just an option that's available.
Yes.
We've got another process, and so it's just an option that was available. So we wouldn't talk about necessarily be doing that, but I appreciate the question. So make sure you understood that. Is anybody in the room? Karen?
Yeah, I was just gonna comment on this because, gosh, it's probably been 8 or 9 years ago. I worked with Oak Ridge National Lab. They have the supercomputer. And so we had gotten together with their public health officials about this particular issue. And yes, there's all kinds of things a supercomputer can do. But when it came down to meeting with the state departments to release the data, in order to make all that work, it hit a brick wall. So some of these data sharing things are regarding state laws. And so you're looking at a whole plethora of possible legislative changes that would allow different state departments to share different pieces of data in order to make this work. Yeah. So I love this. In fact, I would love to have predictive modeling around this for many reasons, on the prevention side too.
Yes.
But it's just, it's a more of a process than I think people realize. And then we tried to do just a local shared database where we would send referrals real time from one agency to another. When it came down to it, the treatment agencies weren't willing to work with us. And they have to be willing to update their data on a real-time basis of their bed or space availability. Right. So there's, this is great, and I would love to see us get there, but I think there's a lot of things we're gonna have to consider before this could happen.
There is a lot of things to consider. I wanted to throw the idea out there because I actually got this idea from you a long time ago. And when I was with the state, I actually talked about with Commissioner Varney, which they're not opposed to it at all. It's just those things. But guys, we got to start somewhere. And I've had numerous representatives and state senators say, hey, if there's anything you need from us to help you, then come talk to us. Well, this would be something we would need. This is not going to be something that happens overnight, because there will be protections in there, and there'll be people that look at that data as their baby and they don't want to give that to anybody. I get that. But I think that's part of us, or part of our job, is to show them why it's important for us to help Tennesseans. And obviously we can get turned down on it, but I think we do have to start somewhere and understanding, what the idea is around that, and then looking at the barriers and how we overcome those barriers, because it'll take a while and it will be a process. But I'm not going to let the process stand in the way of presenting it in a vision forward and us working in that vision.
And to that point, is, some of those considerations we may be able to, learn from in terms of how the state approached it with the psychiatric hospital bed boards.
Yeah.
And they went through that and all of the difficulties that you're talking about in terms of sharing protected information and putting those BAAs and those contracts in place took a long time, but it would take a lot longer. I mean, a lot less time if we modeled it after something that is working.
Yeah, they already had that in place. And so, I figured that out, being able to work with the department to do that and see what avenues they took. I agree with you.
Yeah.
In the time constraints we had here today is just presenting the idea, because I think that, even if we didn't have this money to expand all these programs, how different would Tennessee look if we just better utilize what we already had? And I think it would look markedly different, because I know the services that are out there. But a lot of times right now, the only way you can find those services is, somebody like me or Lisa or Karen who knows where they are. And I think that those are things we need to work towards. Anybody else have any questions? And that Jared and his group will be available offline to be able to answer any questions that we have. And we got one more presentation that will be very long. Sorry, Jared, I can't do anything about the train.
No problem.
Jared, I know. Yeah, apparently it's going in the back door. We have, and Rayford Etherton will give us just an overview of systems dynamics. And I promise you it won't be long. We won't be far off schedule. I got us off schedule, so I apologize for that. So Rayford, if you don't mind.
Yes, sir. Thanks, Steve, for having me here today. My name is Rayford Etherton. I also would like to thank Mary for her help in getting everything set up so easily. And as I said to her, we are working all over a lot of different places in the country right now, and y'all are to be commended for the very intentional transparency about your process. That is not always the case everywhere. So I start by saying I'm a recovering attorney. I've been clean for about 20 years now. And in the last iteration, we started a consulting group about 5 years ago with an idea of working on behalf of victims in litigation that involves systems that have gone awry. And we were very fortunate to be in the right place at the right time. Before we even had a name of our company, we had been retained by one of the 3 law firms that were leading the MDL opioid litigation that has resulted in the settlement monies. I work with guys principally at MIT who use a really cool type of simulation modeling called system dynamics. It's been around since the late 1950s. It was invented at MIT by the same person who invented magnetic core memory, or what we call a computer. And what it does is it's a type of approach that allows you to model the world as things actually happened. For example, in this case, the number of opioid deaths, OUDs, other types of data that we know about, and then to go in and simulate what would have happened, but for, in this case, industry's behavior. And so what our modeling, we were retained first by the lawyers at the MDL to build a causation model that could explain it, and to show that, as Dr. Jackson, I heard one of your earlier sessions so elegantly described the opioid epidemic as it did unfold over time, and to show that really the introduction of OxyContin did in fact lead to where we are today, and that these events are related, and our modeling shows that in a very transparent way. The folks liked what we did in the MDL, and so since then we've built a national model for Native American tribes because they are affected in a unique way. We've also worked with people in the state of Nevada, state of New Mexico, state of Texas, state of Alabama. And so we've been literally doing this daily for the last 5 years. That's how I met Steve Lloyd. And as we started transitioning from the litigation, although there's still some out there, it occurred to us that it would be good to get like-minded individuals together who kind of know what's going on to help transition us from the litigation focus to the abatement focus. Because what we're seeing all over the country is that there is consensus that things need to change, but there's not consensus on how exactly to do that. Particularly as we have in Alabama, I'm sure you have here, in small rural counties that really don't have much of an idea even about what they want to call abatement. So we founded the Helios Alliance, which is a nonprofit. And what we do is that we work with experts from across the country. And what we want to bring to the table is to work with decision makers like yourself, like for the Opioid Abatement Council, to build a simulation platform. We already have the national model and we have the beginnings of an abatement model, but to build a comprehensive simulation platform that is informed by artificial intelligence that would allow decision makers to make the smartest decisions possible. So that, for example, before it would allow you to take into account what programs, practices, policies, interventions, or combinations of those things are most likely to work and are most likely to fail. Before you have to deploy the money and come back in 3 years and go, well, was that a really good decision? We think that we come as close as anybody in the country, I know we do, to kind of take the guesswork out of this process. And it is very nimble. It's like running what if scenarios on steroids. And one thing that we've already done, and I've mentioned this to a couple of you, is that, yeah, the Narcan deployment is certainly important. That does really good stuff. But we have already taken the model that we have right now, and we ran some scenarios to talk to you about today. And while we had a $10 million spend for Narcan over 5 years, in our model that reduced overdose deaths by 10,000, but it also increased the number of opioid users by 11,000, because which just shows that you really do have to look at the entire system to figure out what is the best plan to abate the opioid epidemic. That's kind of what we do. Any questions? Be happy to take it.
Thanks, Ray.
Yep.
All right. I appreciate you getting us pretty close to back to being on time. We thank you. So Lisa Tipton is going to share a video with us of recovery court, I guess here in Washington County in our local area. And actually, Lisa, if you would talk about our tour later today, if you don't mind.
Yeah, sure. I'd be glad to. And I feel like that was a great lead in with Ray earlier, talking about smaller rural counties. And we're in a very rural part of Tennessee. Some of the counties we have are small. Some, like Washington County and Sullivan County, are pretty good sized counties. So the video that we'll be showing is really how we've captured a dream and a vision that we had for our region. And Families Free serves families across Northeast Tennessee. And our primary point of engagement for years was families involved with Department of Children's Services. So working with families involved with children's services, we saw all the different systems. We saw the social determinants of health. We knew about ACEs 20 years ago because that's what we were seeing lived out in the lives of these families, and mainly the children, and what it looks like to grow up with a mom or a dad or a grandparent who is addicted to drugs and the chaotic effects that that brings into the lives of children. So that's my disclaimer. That's always my first dog in any race. I'm always looking to improve the lives of children and families. So about 8 years ago, we began working with moms that had drug exposed babies. NAS got a lot of attention. It got a lot of national attention, local attention, state attention. But where I was spending most of my time was in the NICU, in the homes of moms with these babies. And it just did something to me that I haven't ever gotten over. So at Families Free, we're seeking to improve the lives of children. We're seeking to improve the lives of families. And the people that you'll see in this video that came together for a unified vision for our region see literally thousands of individuals a year. Our judges, some of our mayors who are on there. And what this group did is we got a vision with the very first settlement dollars in any significance that came to our region. That was the baby settlement. And because we had taken care of so many of these moms and children and families, we were a big part of that action. The judges were a part of that action. And we have had a group of mayors come together in our region to pull $10 million over a period of time for a men's facility, also for a women's facility. So you'll see some of that depicted today. We're very grateful for Governor Lee's investment in this project, also for the department's initial investment, then an ongoing investment to fund a lot of the operations. So I'm glad we get to have this time. I will ask Mary to share the other slides I put together about some of the work, but I won't take time for that today, but I hope you enjoyed this video.
Equipped to do that.
Okay. I have a technology issue here.
Lisa, are any of the judges going to join us this afternoon?
Yes, and we would like to invite any of the council members or state staff that would like to come. And I know Judge Street will be there. Representative Hicks will likely be there. There's a lot of trials in our area right now. So Judge Goodwin and Rice and Boniface are iffy, but Judge Street will be up there.
Yeah, for those of you that don't know, there's an attorney general locally, Barry Stavas, went after the pharmaceutical industry on behalf of babies who were born drug dependent and won a settlement that just this area got the money for. And they've taken that money and established a treatment facility that we get to visit this afternoon that is going to work with patients who have court involvement. And so, you know, for Northeast Tennessee, it's a really good thing because we've never had a facility like this before. So if you can, I encourage you to join us. Judge Rice, Judge Goodwin, and Judge Street, you know, have been involved in this and care about it deeply. And then our representative of my neck of the woods, Tim Hicks, is the same way. So I hope you all can join us this afternoon for that. And that's Judge Street, by the way.
I'm sorry.
That's okay.
This is where I don't know what to do.
Yeah, we struggled with kind of technology when we got here today, so we're sorry about this, guys. We're trying to get it figured out. Work on it and circle back to it.
Yes.
Okay, we'll do that. You'll have to take a break, Mary, because the next part's you, and then we'll circle back to it if you want to.
Okay, sorry, Lisa. Let me work on this during the break.
Uh-huh.
I don't know how to.
We'll get it.
All right. Sam and I will figure it out in the break.
So Mary's going to give us an update on the Opioid Abatement Council office. She's already given you a preview. We do have a deputy director who I don't see here with us, so I think is she online?
No.
Okay, so we'll just make the announcement about that, but you can go ahead and be ready.
So first we would do a public comment update. And oh, good. Okay, so I'm going to let Sam Bookley talk about a public comment update.
Sure, and I'll be brief. This is more of just a PSA for the council as far as the legislature had made changes that went into effect in July this year as far as public comment. Essentially, if you have a meeting that's subject to the Open Meetings Act, you have to reserve public comment. This doesn't really impact the council because the council already affords public comment. But the reason for bringing it up is within that statute, it specifies that if you're going to, I guess, limit public comment in any way, you have to have certain parameters around that. And what I will say is if the council doesn't want to do that at any time, please come to legal before making that decision. But again, I don't believe that impacts us. I just want to make sure y'all were aware of the recent change.
Thanks, Sam.
Any questions for Sam? All right. So yes, Sage West, she goes by Sage, will be our new deputy director, and she will begin employment on October 16th. She has worked for the Department of Mental Health and Substance Abuse Services in the past and is currently working as a senior vice president at Volunteer Behavioral Health System. So at this time, Dr. Lloyd and I wanted to make sure for the community as well as the council that she will not score any applications submitted by Volunteer Behavioral Healthcare System. We will locate another scorer within the Department of Mental Health to score that application. So excited about bringing her on board, and she will be an amazing addition to our team. All right, and just real briefly wanted to share with the council our current tasks and activities. Y'all can read through those. I'm going to catch us up here. And then our upcoming tasks and activities, definitely onboarding and training of the new staff, managing the scoring process, and scoring the applications, preparing for next year's county payments, and compiling the county semi-annual reports. So at each meeting, I like to give update on the balance of the Opioid Abatement Trust Fund. And this is our current balance. We are at $95,147,777.87. At the last meeting, there was some questions about the monies that we're spending. And then also in consultation with folks at the department, I wanted to bring this to you guys and make sure that how the council, or sorry, how the office is scheduling the quarterly meetings is meeting your expectations of the office. We have to move around the Grand Region according to the law, but in absence of any other precedents, when I took over as executive director, this is how I've set up the meetings. So I'm wanting to hear from you guys. Is this working? Are you in, is the space working, the audio visual working, the food service working? If there are any ideas or any changes that you would like to make in this, the way we operate this, please let me know. But this is all the meetings that we've had, and then a breakdown of the quarterly expenses. So the majority of the expenses right now are staff compensation. The meeting spaces have been free. Thankfully, we haven't had to pay for any meeting spaces. So aside from that, it's been the lunches, which are averaging between $350 and $500. I'm sorry, not averaging, but the span from $350 to $500. And then the member travel, which is based on CONUS rates. So I'll pause right there. Clay, I think you had a question about the expenses. Is this meeting the needs? Is this the information you were hoping to see?
Yes, thank you very much.
You're welcome. So I don't know if you guys want to vote on this. I put this in here as a reminder or just a little tickler here. If y'all have any suggestions to how we organize the meetings, I'm definitely open to those. So I'll pause right there and for discussion and questions.
Mary and I talk, a lot, and we want to put everything we can before the council for a vote. We do have to rotate between the 3 grant subdivisions, which I think is good. And I know for the folks in Memphis and Clay, that's a long way to Northeast Tennessee. And then our next meeting will likely be in West Tennessee, the same thing there. We try to do our best, but Tennessee's a long state. So I would like for a motion so that we at least have we have it on the record what the council's wishes.
Make a motion, we maintain the status quo.
All right, got a motion from Judge Sexton to maintain the status quo. Do I have a second?
Second.
A second from General Allen. Anybody have any discussion? Okay, with that said, all in favor?
Aye.
Opposed? Sorry, guys. Opposed? All right, motion carries. I keep forgetting I have people online and there's a little delay. Sorry about that.
All right, thank you, guys. All right, next up, Opioid Abatement Council legal support. And you want to talk a little
I shall. So we met with the Attorney General's office since the last time that we all got together. And the question was around legal support for the council itself. And so what we had been doing, and Sam is here today, and Sam, I'm grateful you're here today. It's not an indictment of you, by the way, was having counsel that represented our interest, the department's interest, because there was a meeting in the past where there was a statement made that didn't sound like that was the case. And I feel like, as our chair, that we need somebody that represents our interest and not the interest of the department or anybody else within the state. It needs to represent our interest. And the Attorney General's office was great with that. And again, not an indictment of Sam at all. And so when we met with them, we basically have 2 options. One option is to continue to do what we do now. We have representation from the department, but when Sam is here, he is representing this council, not the department. And he understands that. And also, you all already know that online, we have 2 representatives from the AG's office. And we've been working with Lacey Mays, who is wonderful. And Lacey assured me that we will have AG representation at every one of our meetings. So that is the first option. The second option is that we can hire our own counsel. And so I did a little digging in that to see how much that was, because I want to know how much things cost. And it looks like that's somewhere around $4,500 a month. It would not be a full FTE, as you all could imagine. We don't have that much that we need help for, but those are basically our 2 options. And so again, in the interest of wanting the council to make these decisions, I wanted to put those before you for discussion, and then a motion to whichever one that we would like in a vote.
Sam, you're here on behalf of, who's your client?
My client, for the purposes of here, is the council.
So we are represented at this point by Sam.
Right. Sam he works for the department, but when he is in this role, Sam represents us, as do the 2 members of the Attorney General's office.
Well, I guess we'll make sure that we don't fall into a conflict there at some point. I mean, there may be interest going different directions.
And that's something that we talked a little bit about when we were meeting with the AG's office. And if, so Sam being a standalone attorney while representing the council, if there were questions or, something that needed to be discussed, then he would reach out to Mike Stahl or Andrew Coleman in the AG's office. So it wouldn't go to the division of general counsel at the Department of Mental Health. Am I representing that correctly?
That's accurate.
Okay.
What would be the benefit of hiring one if we had that battery of lawyers available?
It's a reason for discussion, right? I mean, that's just exactly what you said, that potential for a conflict at some point. I mean, I don't see that, but I wanted to have that option there because the AG's office did give that option to us. Yes, John.
Well, I assume if that conflict ever developed at that point, we could hire a separate independent attorney and in the meantime, save $4,500 or more a month. And be adequate and be more than adequately represented by Sam.
No, it's just the reason for discussion. The AG's office gave us that option, and I didn't want to just table it and not bring it before the group. So that's exactly right. If we ran into that and we felt like we had a conflict, nothing prevents us from changing course going forward.
Clay Jackson has a.
Dr. Jackson?
I think Shane asked the right question, and I think Sam gave the right answer. Who's your client? It's OAC. And then the next question is, where's the reporting structure go? And it goes to AG, not to the mental health department. So I'm satisfied right now.
Okay. Thanks, Dr. Jackson. So is that a motion?
I move.
Shane, I'm sorry, Judge. Judge just asked a question, do we have to do anything? If it's okay with the council, I'd like to, because it removes all doubt, and I'm good with that. Keeps me out of trouble. So go ahead, Clay, if you're okay.
Put the previous slide up, Mary, please. I move that the OAC continue to utilize the services of the TDMHSAS DGC attorney assigned to us.
Second.
Provided that this attorney continue to report to the Attorney General's office of the state of Tennessee.
Okay, so I got a motion on the floor. Do I have, I think I heard a second, but I don't know who from.
Ken Moore, second.
All right, a second from Mayor Moore. Any discussion? All right, all in favor?
Aye.
Opposed? All right, the motion carries. Thank you, guys. All right, Mary's going to give us an update on community grants.
Yes, okay, lots of activity, lots of activity. And this was as of September 29th. I've not gone into the portal today, but we had 255 organizations registered. We had 260 draft applications. We had 546 views of the training video. So thank you guys for watching the video. At that time, we had 10 submitted applications. So I imagine we're not going to see as many applications coming in at this point because we extended the due date to October 16th. So that gives folks a little bit longer time to review their application. Technical assistance inquiries. I've never been a help desk before, so this has been some OJT for me. Around 55, we have people call in or email, and then there's follow-ups, several follow-ups around that. Some of the questions, I mean, it ranges from how do I find the portal? There's also other Smart Simple portals out there that people have tried to enter to find our application. So getting them to the correct portal, not much around using the application itself, but more around registering. So there's been some issues with registering. And I'd like to say we have already put together a document called 2.0, and we have a good number of lessons learned and ways that we hope to improve, always improving the process, improve the process for next year. As far as technical issues, and this really isn't a technical issue, it was a system limit. The system had a cap on how many zip codes could be loaded into the application. And instead of just having all 95 counties there, we loaded all of the zip codes because I gave the example, you know, I live in 37211, but my kids go to school in 37215. Those of you who live in Nashville know that those are two separate parts of Davidson County. And if someone is going to be providing services in 37211, that is different than Green Hills, where my kids go to school. So I wanted to have that separation, but we loaded all the counties in. So if someone is wanting to provide services in 10 counties, then all they have to do is load those 10 counties. So just wanted to share that with you guys. Otherwise, Smart Simple seems to be working very well. Elizabeth, real quickly on training the council members.
Yes, all council members are completely trained. You all received A+. Everyone did wonderful. So. Take it, Shane, take it, Shane. It was, you guys made it easy and I appreciate it and you all worked well through it. So if there's any questions, as we discussed before, you all can get back with me and go over it, but thank you all.
Did you say Shane had been successfully trained?
Shane, he is A+.
All right, y'all must have done a great job, so thank you.
Dr. Lloyd and I wanted to revisit the grantee payments. So I think we have discussed the quarterly payments before, but you want to take this one?
I do, and Tommy, I know you're on here. It's weird not having Tommy in the room, but Tommy Farmer is a special agent with the TBI, and Tommy actually brought this to my attention, and then I called some other people. Karen helped me with this as well. We looked at quarterly payment to our grantees, and really the feeling is that we may have some grantees that's going to put a hardship on. And so I wanted to readdress that because, that's why, Shane, I want to bring things before our council, because I kind of unilaterally decided that one in our talks with the department, because the department will wind up distributing the funds. That's what will happen. And so Mary and I met with Commissioner Williams and we looked at quarterly payments and thought that would be the way to go. But after discussion with Tommy and Karen, I'm not quite so sure. So Karen, do you mind to explain a little bit about why this is an issue?
Well, the way grants work, at least currently, is you have to spend the money before you can invoice and get reimbursed. So an organization has to be able to cash flow and pay their expenses before a reimbursement. And that reimbursement, the department usually turns them around within, 3 to 4 weeks. So you may be 8 weeks out, depending on when it is during the year too. When a new fiscal year starts for the state, sometimes it's a little bit slower. But we're fortunate that we can cash flow these things. But if you're talking about smaller organizations, especially in our rural communities, this could create a hardship for them. So I would recommend, a minimum of doing monthly invoicing so that people can cash flow and keep the work going and not have to worry about paying their employees and all of those things.
Thanks, Karen. Does everybody understand the issue here? I think it's pretty clear. And I want to tell you the rationale for me behind the quarterly one is I didn't think of everything, which is not uncommon. But the other thing is that we're standalone council. We don't have, a finance or accounting department over here. And so I was looking at the stress that it would put on the department to do that. But I think after further discussion, I'm not sure that's as big as issue as probably what I thought it was.
So question, are y'all thinking about moving to invoicing rather than just paying the grant? Because right now we don't have it set up for invoicing.
I just wanted to comment. That's exactly what I was going to say. I think that one option to circumvent this may be to pay out the money potentially quarterly, where it's not being invoiced, and have a quarterly reconciliation. Maybe that reconciliation is due before the next payment goes out. So for example, if somebody's awarded $1 million, at the beginning of the first quarter, the first payment period, they get $250,000, which they will then use and then have a reconciliation that's due before the next 250 goes out. I think that would reduce the cash flow issue for a lot of the smaller organizations, but also allow us the transparency and reconciliation. So maybe they have to do a 60-day reconciliation so that we have that 30 days to decide if they're going to get that next 250 or what. I mean, alternatively, if the council has decided that we want folks to report semi-annually, maybe we have to require the reconciliation at the 4-month mark so that we can decide if we're going to give the second half of the funding for the year.
And I think that could work with our staffing. We have 2 accountants that are going to be in a separate part, be in another part of the Department of Mental Health that are overseeing the fiscal part of this, but then we have the 2 grants analysts who can also help. The invoicing, we would definitely need many more people to help out with that, but the reconciliation my limited knowledge about what's going on here, I think I would like to take that back to Paul Havacek and make sure that that's something that two people can do. I don't know.
Yeah, Lisa.
I also am curious and think it would be a good idea if we have a timeline for people having worked with the department for many years. And when you're on a track of a grant that's well established, those turnaround times that you're talking about, I think are fairly consistent. When you get involved with a pilot program or an appropriation that runs through the department, it's just a slower process. And it could be 90 days. I mean, it could be quite a bit of time. So my first question is, will these disbursements to the entities need to have a contract?
Yes.
And if so, that's a whole lot longer process. And I'm just curious because I feel like we need to let agencies know if you're approved for $1 million, you'll be front loaded that money each quarter and you reconcile before the next quarter. Getting through the contracting process, just what a ballpark idea Matt might have of what folks could expect.
So we're looking at like March, April, and May to be the contracting time. And we're hoping or planning, and correct me if I'm wrong, Sam, that there will be a blanket contract with, and depending on 1 year, 2 year, 3 year, depending on what type of grant they were awarded, but the scope of service would be their application. Did I characterize that correctly?
Yes, so I think the thinking, as I understand it, whatever proposals the council approves, that will be embedded in a standard scope of service as an attachment. And that's one way we can expedite the execution of these contracts. I think the other thing I would say too is there's a lot of other agencies that all contracts have to go through coming out of our department. You know, there's Central Procurement Office, there's Finance and Administration. So, I mean, we move as quickly as we can. The other thing, and Sam could speak to this, I think, is as far as how these funds are considered. I mean, I don't think they're considered state funds, they're not considered federal funds. And we've had some discussion about, you know, is there more expedient way to get the dollars out the door in that they're settlement dollars, and all the provisions that apply to typical grants apply here. I think the conversation about payments is a good one. Karen's absolutely right. It's a state rule that with grants coming out of state government, they're generally cost reimbursement. The costs have to be incurred. But I will say, looking at that third bullet related to capital projects, there are instances where, you know, a grantee can incur $1 million cost on the front end. And there's ways to address that. But as far as our department and with these new staff, I think as soon as these grant applications are scored, approved by the council, we're looking to move to get things moving out the door and get the grants out the door ASAP. But having the scope or having the proposal embedded in the scope so we don't have to personalize every grant that y'all select is going to be a huge time saving. And then y'all can hold the grantee accountable to what they submitted. That's how those will be monitored against.
So I think just for operations, what I need to know is, are we paying quarterly? Is it at the beginning of the quarter or the end of the quarter? And is there any paperwork that y'all are wanting the grantee to submit in between payments, or does that get submitted with their semi-annual report? Is it different?
Yes. And I think a follow-up to that as well, just so we're very clear to the people applying what's a realistic time frame to expect. Mm-hmm. Are there going to be any of the standard boilerplate language of how much liability insurance you have to carry if you're following all the title, gazillions of titles of things? I mean, what do agencies need to be prepared to have in place infrastructure wise to not be impeded in getting their funds?
I think it's a great question. It's one that Heather Gunderson, our Deputy Commissioner for Administrative and Regulatory Services, just discussed a few days ago. I mean, we don't want to apply any provisions to these grant contracts that are not relevant to the type of funds supported. So in that these are not state funds, they're not federal funds, they're settlement funds. There's going to be things that I think grantees of our department are accustomed to seeing that may not be pertinent to a opioid abatement council grant. I think some of this is going to involve us not just talking internally, but probably maybe with the comptroller's office to get a better sense of what their expectations are. And it may be that a lot of these provisions within the standard contract are not relevant here.
Stephanie Vanderpool.
So I would move, if we're ready for a motion, I'd move that we make the payments quarterly at the beginning of the quarter and require a reconciliation prior to the distribution of the third payment. And I'm going to give my rationale for that. So if you do a quarterly distribution, I don't think we will have enough time to reconcile that first quarter, those first 2 months. It takes a while, as you know, many folks who've received grants will know, to start and ramp up your spending. But I think if you're trying to provide sometime in Q2 reconciliation of how funds in Q1 were spent, and then we have time to evaluate that reconciliation before we decide if we're going to distribute the Q3 payment. That's my rationale for proposing quarterly distribution of funds, but reconciliation after this, reconciliation of the first quarter funds within the second quarter before the third quarterly funds are paid.
We got a motion on the floor. Do I have a second?
Second.
All right, a second from General Allen. Any discussion?
One point, how much work is this going to do for the staff when it comes rolling in like that? How quick can it be turned back out?
And that's a good question, Shane. And in all honesty, I may come back to you guys in February, March, April, May, and ask for another position or 2 more positions, depending on the volume. I mean, we know how many we saw how many draft applications there are. Those haven't been submitted, and then y'all haven't approved those applications. So depending on the percentage of those approved applications, we'll predict how many people we're going to need.
We don't want to be the choking point, and that's what we're looking at if we don't look out.
I think that's a great point, but we do have the flexibility to come back if we see, because you all saw the numbers. I mean, my guess is that as time goes on, I expect those to probably increase, just looking at it. Any other discussion? All right, all in favor?
Aye.
All right, opposed? All right, the motion carries. We've got a 15-minute break scheduled. I'm going to trim it to 5, give everybody time to go to the bathroom, get us caught back up while Sass gets ready. And oh yeah, please grab lunch if you can. Maybe a little closer to 10 minutes. And so it's 5 after right now. So let's look at 11:15 or 12:15. Sorry, I'm still on Central Time. Thank you all. Yeah, sorry, Clay. I wanted to recognize just a few people in the room, if that's okay. We sent out invitations to a lot of people when we knew we were coming here, and I actually knew when we sent the invitations out who would come, and they did. So the first one is Dr. Rob Pack behind me. Rob he's a bigwig, and he works at the College of Public Health, and Rob has been a friend of mine for a long time, and just respect Rob to death. So Rob, thank you for coming. And I don't think Sarah's still here, but Sarah Melton was in the College of Pharmacy. Sarah taught me how to use Narcan back in the day. And I don't know how many people she's trained in Narcan now in the College of Pharmacy. I mean,
tens of thousands.
It's in the tens of thousands. And Sarah lost her husband a few years ago, Hughes Melton, who was the head of mental health and substance use in the state of Virginia. And Sarah and Hughes have been really good to me in my life. And then to my left, he may look a little older, but he's still spry. Dr. Tom Quasagro. I met Quas in 1995, the first day of med school, and he's been like a father to me since that time. And I love him dearly, and I appreciate you coming, Quas. You bet. All right, so Jeremy, is it Jeremy? Okay, Mary.
Sorry, I've got one thing that's not on the agenda. This was late breaking before, happened as I was pulling the agenda together and sending it out for printing. But I just wanted to make sure that all the Opioid Abatement Council members received the email that I sent out Friday evening, alerting you guys to the percentage mismatch. So we had an inadvertent miscalculation on the scoring percentages. So we've been able to correct that. at least visually within Smart Simple. And then over this next week, we're going to work with Clay and STS on testing and making sure that when the scores, the raw score is presented, then it goes through the weights that Karen and the subcommittee pulled together in order to get the actual score based on what the Opioid Abatement Council wants to see. So that is up next. I have full faith in STS that we're going to be able to pull that together. Clay, I'll pause right there. Anything else that we need to share with the council?
So you guys may have received an email. Thank you, Mary. What actually happened was, if you remember from your training, when you're looking at the scoring of the rubric, the percentages of scoring were not equivalent to what the council had voted on. So we corrected that to ensure that those matched. There was a second error in the way that the computer programming was constructed. It was constructed where if someone hit that they did not want to sustain their project beyond the grant period, or if they did not want to integrate, the way the programming worked, it would not penalize them for that. They would not lose those points. They would just get less score, and it would be standardized to 100%. So we've corrected both those errors on the application, but we needed to inform you as council members. And then Mary has also emailed the community for all those that had a draft application in, so that they understand the error that was made. If we do have any proposers who feel that this created any kind of hardship in their application, or they, let's say they didn't want to do a sustainable project because they thought it wouldn't penalize them and they feel they need more time, then we have proposed that we would give them an additional 2 weeks if they presented that as a challenge, just in order that everybody had an equitable opportunity. And we didn't want this inadvertent calculation error to improperly penalize anybody who was applying. Does anybody have questions about that? Because people might ask you, why was this percentage and then that percentage? Maybe nobody notices, but we just want to make sure that everybody's aware how you'd respond to that and why that error happened and why we corrected it.
I have a question, Clay. On the sustainable versus non-sustainable projects or past 1 year, are we penalizing projects who are designed to only be 1 year? For example, maybe there is we're going to do project X and the goal is to get this out one good time and we don't plan to continue it past a year. Is that therefore going to be penalized?
It will be, because the council voted on 7 ways to value these projects. And so there may be a very good project that says, we're only going to do this one shot and we don't care what happens beyond that. But if they're great on the other 6 areas, then they might have an 85 score out of 100. But we voted that one of the 7 elements that we wanted was, we didn't want to just fund projects for that time. We were interested in ongoing impact. And so it's not that they're at a disadvantage to anybody else. They had the advantage of having sustainability, but we valued sustainability. That's why we put it in. Somebody might say, we're not going to integrate with the healthcare community. We don't care about integrating with everybody else. We're doing our own thing. Well, they might do excellent, and we might choose to award them based on their score. Their score might be great. Their score might be 2 points below somebody else, and we say we're still awarding them, and we're not awarding somebody that had a 2 points better score. There might be reasons for that, yet somebody couldn't just put not applicable and then not be graded on that. We chose to grade on those things, and so we want the reviewers and the council to know, that they basically said, no, we're not doing that portion of it. Somebody might say, we don't want to have an impact. We just want to study things. We don't care about people. I don't know why anybody put that on an application, but they lose all the impact score, right? So we want to make sure that the rubric also had a 0, not just a 1, 2, or 3. You don't get a 1 on your paper just because you sign your name to it. It's possible to get a 0 on all the scores. So we're going to clean that up this week. We can report back to council if need be, but we just want you as council to know why that email came out, why those changes were made, in case somebody said, wait a minute, we applied, it was 13%, but now it says 15%. What happened? That's what happened.
Thanks, Clay and Dr. Vanderpool. Anybody else? Thank you all. All right, so Jeremy, you guys are up.
Well, thanks everybody for your time. Good afternoon. It really is an honor to be with you today. We really do treat it as an honor and a privilege to be here. For those of you in here that I haven't met before, haven't worked with before, my name is Jeremy Davis, and I'm with SAS Institute. Been here about 5.5 years now, but before coming to SAS, I was actually a Tennessee State employee for 14 years. So I was in the Senate for about 7 years as a staffer there, and then the last 7 years, I was actually most of the Haslam administration. I worked at the Department of Health, where I intersected with a number of the folks in the room here and actually online as well. And I'm grateful for the opportunity to continue building on those partnerships on the opioid front. With me today, I have Kay Meyer and Sean Berry. They'll introduce themselves in just a moment. And we've got a battery of other SAS folks online that are really honored to be here with you guys today. We've heard a lot about data and analytics today, and we are a data and analytics company. I do want to say that we embrace data as a platform. So one of the things that really differentiates us is the ability to encapsulate all data, not just certain niche data, and bring all of it together in one area. It embraces all sorts of different analytics. We partner with all sorts of different vendors in order to do this in one centralized location. So just kind of want to leave you guys with that, or begin the conversation with that. If you're anything like me, though, I came from state government. I was microbiology, posted my training in Tennessee Tech and Cookeville. I had never heard of SAS before coming to SAS. So I figured it might be helpful if I told you a brief introduction about who SAS is, what we do, and then I'll turn it over to Kay and Sean to talk about that. So like I mentioned, we are an analytics company, data analytics company. We were really founded for government by government. It was a government grant, USDA grant, to bring together copious amounts of disparate data to solve for big and complex issues. That's what we were started to do. And we are still finding that day to day. That's what we do for governments, especially. I like to break it down into 3 different things that we do. We take big data, bring it together, and apply analytics to it so you guys can get the most intelligence from the data that you already have to help guide your decisions. So that in a nutshell is kind of really what SAS does. But I do want to talk a little bit about SAS in Tennessee. So if you go to the next slide here, I won't go through all of these agencies. The big picture here is we are already present in 17 different state agencies in Tennessee. We know the state government, we know state government data. What we range in could be just a handful, 2 or 3 users, SAS users using our software in an agency, to full-blown solutions. So, and how have we gotten there? We feel like we are that trusted advisor, that trusted partner when it comes to analytics. And we are also on statewide contract, which has facilitated greatly our ability to be able to get in and talk to agencies about our analytic platform. I know the council has the process put in place. I do want to just offer that up as a little bit of a different. The fact that we are on statewide contract and everything has been fully vetted, fully negotiated with SDS, with central procurement, with all of those. We have done all of that. So that's really kind of us in state government and our footprint here. I do want to turn things over to Kay and Sean to talk about what we actually came here to talk about. But before we do, I definitely want this to be kind of conversational. Please, if you have questions as we're going along, it can be kind of complicated, weighty subject matter. Please feel free to ask questions as we're going along here. If you want to wait until the end, that's fine too, but we find it's best to answer questions as we're going through the presentation. So with that, I'll let Kay and Sean take it.
So would love to introduce myself. I'm Kay Meyer. I'm the Director of Industry Consulting for a U.S. government practice. Similar to Jeremy, I'm also a former public servant. I worked for the state of North Carolina for almost 20 years. And as part of that role in North Carolina, I worked on large-scale enterprise analytics programs, which involved data sharing of some of the most complicated data sources. So I heard you when you talked about the challenges with data sharing, but bringing really more comprehensive data and analytic capability to some of our most challenging problems. And Sean?
Sure. Good afternoon, everyone. Sean Barry is my name. Also, like Kay and Jeremy, I am a recovering state employee. I worked in the state of Ohio, as well as my home state of South Carolina under various administrations and in various roles. So my role at SAS is very much complementary to Kay's. I lead a team that looks at all things related to fraud, risk, and integrity in government. And that remit does include drug abuse and policing, public health, looking for public health risks. And so Kay and I have teamed up on many of the activities and projects that we've done around the country related to opioids and addiction.
So we thank you, as Jeremy did, for having us here today. And it's been impressive to hear what we've heard today during your meeting and to hear the passion that you have for changing outcomes for the state of Tennessee. Similar to you, we have been working with groups from many different states and many different organizations that are focused on tackling this challenge. And we recognize the diversity of impacts that this challenge is having on your communities and your citizens. We recognize, I loved the analogy of the bathtub with the faucet and the drain. There are many factors that affect whether or not a person gets into this situation of substance use disorder, and many different ways that they have an opportunity to exit that as well. And so as a recognition of that, we've put together a very diverse multidisciplinary team that's helping us work with our partner organizations in government to help address this problem. Folks from law enforcement, folks from public health, pharmacologists, epidemiologists, but also deep data scientists, legal and policy experts as well. And we recognize that it takes all of that, a wide community, to be able to share ideas and help us find the kinds of solutions that are really going to truly make a difference. If we can go to the next slide, as we look at our capabilities, as Jeremy said, we've heard about a lot of different specific scenarios today. What we bring to the table at SAS is a broad platform or a broad capability that allows us to focus data integration, data sharing, and analysis across a wide range of areas that are impacted by the opioid crisis. Everything from, as you just heard about the recovery courts, everything from justice and public safety, and recognizing that there are many, many different opportunities to have interventions within the criminal justice system, to behavioral health and the intersection between that and substance use disorder. We do work in disease surveillance, so understanding what is going on in your communities and providing you the kinds of tools and capabilities that allow you to anticipate, if history holds true, what's going to happen and what kind of interventions may change the trajectory of those. And today we're really here to help you with some of your initial phase work and creating a foundational capability for data and analysis in making some of your settlement allocation decisions. Okay, go to the next slide. So in looking at the proposal that we have in front of the state, we're really focusing our proposal on three key pillars. One is providing data and analytic capability that will allow you to have better informed decision-making as you go through your grant allocation process. Now, this involves creating a repository that can centralize data from a wide range of sources, give you access to that data on a more reliable and trusted kind of capability, and allow you to begin to understand not just what the numbers are showing you, but what's behind those numbers. What are the key factors that are driving those numbers to be what they are? And to allow that to inform the decisions you make about your resource allocation. From there, we are able to then take that data and help integrate with your grants management system and provide you some insights on your tracking and transparency. As you have defensible information about the decisions you make, how are those funds going out, and how does that overlay or layer with the opioid data that is available from your state? And then over time, to begin to build a longitudinal capability that allows you to track what's the impact of those investment decisions across a variety of baseline metrics and how those are changing over time. One of the ideas that we bring to the table is that this is not research data. This is not a one-time analysis. This is ongoing operational capability that will allow you to see those trends changing real time, if you will, or in a more timely manner, and make decisions or alter strategies and initiatives as needed as you move forward. Any comments?
No.
Okay. Go to the next slide, please. So we've talked about a lot of data today. And, you know, when we work in government, my experience in working in North Carolina as we looked at enterprise analytics was We so often look at challenges within silos of information. We look at one segment of data to drive a decision that we make. Maybe it's overdose and death numbers. Maybe it's the numbers of people who are in our court system. What we realize when we look at the individuals who are involved in the opioid crisis, there are so many unique and different factors that are the things that resulted in this person being involved in this kind of crisis. Whether it's injury, whether it's trauma, whether it's criminal activity. We need all of that information to help us truly understand what is going on and what is the driving the numbers that we see geographically across different segments of your population. We talked about the difficulty in sharing some key sources of information. We work with a number of states in Medicaid. We work with the state of North Carolina on something called the Government Data Analytics Center, which does enterprise analysis across health, across education, across finance and revenue, across criminal justice. And so we work with some of the most sensitive data sources. We have experience not only with bringing that data together and being able to make sure it's good quality and that it matches up effectively, but also managing the governance of it. So protecting the confidentiality, the security of it, making sure that we can control access and usage and report on that access and usage. We have experience with creating the kinds of data sharing agreements that you talked about being so challenging in state government. And so we can bring some of that expertise to the table. And all of that is really to drive reporting and analysis.
One other thing I did want to mention, Kay was talking about privacy and security of the data. We fully recognize this is the council's data, and we never want to limit, inhibit the council to be able to get access to their own data. We want to make sure that we safeguard the nature of the data that's in there. But just want to put that out there. This is the council's data. You are always going to have access to your data. This is your data.
And to follow up on that, I saw a question that popped up in the chat window about HIPAA. We are painfully used to working with HIPAA protected data, all kinds of protected health information, 42 CFR Part 2, criminal justice data. Those are things that we're used to working with those types of standards for these types of projects.
And two of the big engagements that we're actually in Tennessee already is with TN.gov, obviously a lot of PHI, PII, HIPAA related information in TN.gov and Department of Health, one of our big solutions there. So obviously we're very well versed in that data.
And, you know, again, we're using this data, but it's to facilitate your efforts, right? It's not, we're not using the data because we're a program provider out in the field. We're using this data to help you drive your decisions. Sean, do you want to talk a little to some of the data sources that we use?
Sure. So in a lot of ways, what we're talking about is very theoretical. Data, analytics. Wanted to give you some real life examples. And again, in this case, Dr. Lloyd is so passionate, and he got up here in the first 15 or 20 minutes and showed that passion. Our philosophy is kind of, there's a famous quote in American business, which is, in God we trust, everyone else must bring data. And our viewpoint is that we are going to propose to support the council's great passion with dispassionate data that you can use to make good and effective decisions on how you allocate resources and how you judge how those resources are being used in Tennessee. So when it comes to data, data is the oxygen of analytics. We have to have data. What are we proposing to the council for data? We're going to first start with publicly available data sources. These are things that the council would not provide to us, they're freely available to anyone who wants to go out to grab them. Some examples, things like social vulnerability index. Lisa, I think it was maybe you that mentioned social determinants of health, or maybe you, Karen, earlier today. Those also would be there. So poverty, homeless, housing stability, income and employment data, race and ethnicity, access to healthcare. There are a wealth of publicly available data sources that we would bring to the council to be able to use. But that's not good enough. That gets you general data. If you go to the next slide, we also are going to propose to bring, as directed by the council, Tennessee specific data sources. Those are things that we as a private company could not provide. These would be provided by state government agencies, for example, maybe federal government agencies. You can see some examples here. EMS, you may have naloxone administration data from EMS. We've handled that in a state like New Jersey. Very, very messy data. If you are in any, if you work in EMS and somebody's overdosing, if you ask them for an ID, you've got about a 0% chance of getting the actual identity of who that person is. Poison control data, child welfare data that can be very, very sensitive. We've had some success in analyzing that in the past. Your prescription drug monitoring system. We've worked with probably 10 or so prescription drug monitoring systems across the country. We are the backbone in California for their Cures system. And I think we've done some work here in Tennessee as well with your prescription drug monitoring system. Any type of treatment or facility or behavioral health data, law enforcement data. One of the great projects that we've had success in is in the state of New Jersey, where we have been able to marry law enforcement data with public health data. Now, from a technology perspective, marrying the data sources isn't hard. Culturally, the law enforcement world and the public health world just see the world differently. And so you've got this, I'll say it's a conflict of the worldview. It doesn't mean that people are bad or mean or evil on either side, but trying to reconcile that data and getting people to think about it cohesively across people who generally don't work together very effectively can be very powerful. Hospital discharge data, any other types of data sources that might be relevant for the very specific types of questions and allocations that this council is deliberating. Those are the data sources that we would ask for from you. We also then can help as the council and as Mary and the administrative team work together. When you make awards to grantees, it should probably be part of your standard operating procedure to require those grantees to get you data back on their effectiveness and in an electronic format so that you can analyze and compare and contrast grantees. Where's the biggest bang for your buck, frankly? Who's being the most effective with certain types of populations? Those are the types of questions that we believe that the data from the publicly available sources and the sources that are provided via the council can help us. So what I'd like to do next is ask Kate to talk about a very specific model that we've already built in Tennessee to give you some examples and real life examples, because otherwise this is just theoretical. So Kate, talk about some of the great work that we've done with a predictive model for overdose.
That's right. And again, you have a lot of decisions that have to be made. And I think what we all recognize is your local programs and your local services in your communities, they have the best sense of what's going on the front line in their communities. And that's what's driving a lot of the grant applications that you have. The council's responsibility is to really understand and recognize what are the needs statewide so that you can understand how effective and equitable decisions can be made with those allocation resources. So using some of that publicly available data, we wanted to show you just a sampling of the kinds of analysis that we can do. Now, in this particular model, you see a geographic map of the state of Tennessee. And in this column here, what you see are projected overdose deaths and the rate of overdose deaths in this column here. What we're doing is with that publicly available data, as well as some of the social determinants and the factors that are driving these numbers, we're looking at historical data and saying, based on the factors that are driving these numbers, if history holds true, this is what we would anticipate the numbers to be. And of course, if you look at the top of the list, Davidson County is at the top of the list in terms of the number of overdose deaths. I don't think that's a surprise to you. There was, news articles this week about Davidson County being one of the deadliest areas in the country in terms of opioid deaths. But what's interesting is when you begin to look at it from a slightly different perspective, and if we look at the predicted rate of deaths, so this is the number of deaths per 100,000 people, all of a sudden Hickman pops up as one of the top counties. And Hickman has a rate of death of 115 versus 96 in Davidson County. So again, different ways of looking at the data that tells you that while there's a high number here, the rate is very high in a particular county. Now we can begin to drill into that county and understand what are the factors in Hickman County that might drive decisions about how funds are allocated to particular services or programs in that particular geographic area.
Anybody from Centerville? Anybody on the council from Centerville in Hickman County? So we won't pick on them too much. One practical application of this is, as Kay has rightly pointed out, is that if you do nothing today, the way that the trends and the forecast would go is that Hickman is expected to continue to have a very, very high rate. So when the council makes its deliberations and it grants to the grantees from around the state, what you could do is 2 years from now, 3 years from now, you could take this model to say, hey, this is what history would have told us the result was probably going to be. What did happen? Then you compare that to the actual data. So let's say that you have a grantee in Hickman County who gets $50,000 and you expect that that's overdose death rate to be 115 per 100,000. If all of a sudden it's 75 in 2 years instead of what the predicted 115 is that success? Is that a difference? Or if it's 145, what happened? It helps you to be able to ask the right types of questions and delve in to make sure that the grantees that you're giving the money to are having an impact. And if not to blame them, but to say, hey, what's going on in your county or your jurisdiction or in Middle Tennessee? Is there something different that's happening? So it gives you data points to be able to ask the right types of questions to allocate the money effectively.
And the next slide kind of shows a bit of that analysis. So we also have the ability with this analysis to set baseline metrics. This is to understand what the numbers look like today and what they have looked like in history. And based on the criteria or the metrics that are important to the council, to begin to be able to track those longitudinally through time and to be able to show you where those numbers are changing. You have the ability to look at that geographically, by category, and by certain time periods. So again, as Sean was saying, what we're trying to provide is the capabilities to say we've made investments, we expected these outcomes to happen. Are we seeing that as a result? This will again allow you to defend the decisions that were made, to be transparent. You know, we all know when funds in a settlement like this or federal fund allocations, there's a lot of clarity that people want to have about where the money is spent and is it having the kind of impact that you expect. So again, we have that ability to do this in accordance with what the council is wanting to see. And then the last example that we provided was what we call our goal-seeking models. And again, this is a way to really look at what the council wants to accomplish. So if we have particular goals for particular areas, this one is looking at Davidson County. This allows you to say, if I want to have this impact, knowing the factors that are driving the numbers in this county, what are some of the things that I need to be doing or driving resources towards to have that type of outcome? And so in this particular example, it's saying, you know, to reduce overdose deaths by 5% in Davidson County, here's the things we need to do related to poverty, related to opioid prescriptions, related to benzodiazepine prescriptions. So it allows us again to give you tools that you can begin to do some analysis and make those decisions. So that's a little bit of the analysis that would drive some of the fund allocation decisions. Now that you've made those investments, we also have the ability then to work with your grants management system and pull the information from that to allow you to do tracking and transparency, to be able to drill down and look at how funds are being spent by programs, by sub-programs, geographically, by population segments, and layer that in with that opioid data that we had from the other screens so that you can really begin to understand the impact that your investments are making. And then finally, the most important thing I think is really recognizing whether or not you're changing the dials on these things. Are we having an impact? So again, with the criteria that is important to the Opioid Council here, we have the ability to use that baseline metrics, the goal-seeking scenarios, and tell you over time what programs are achieving the kinds of outcomes you want, what perhaps aren't, and then maybe be able to drill into the details of why those outcomes are not changing the way you expect them to. Now, that's just a little bit of a scenario of what we can do by bringing in a breadth of data and working with all of your key stakeholders. Some of the work we've done in other states, I think, is also relevant as to where this particular kind of capability could expand over time to address other areas beyond just your settlement dollars.
Absolutely. So the example that I referenced earlier was in the state of New Jersey, under the direction of the Attorney General, who kind of unique in New Jersey. The Attorney General, like Tennessee, is not elected. It's an appointed position, but the Attorney General also controls the controlled substances reporting system, as well as has direction of the state police. So you've got one agency that does all of that data together. We created for the Attorney General's office there something called the IDAD, the Integrated Drug Awareness Dashboard. The problem that New Jersey had is the same that Tennessee has, which is you've got people who were overdosing from prescription drugs, as well as illicit drugs and illegal drugs. And you squeeze the balloon on one side and it would pop out the other. And so they wanted to stop this dynamic that they could foresee coming when they would crack down on prescription drugs in a given area. So here's where we married together data from law enforcement. So it was arrest data. There was some conviction data, not a tremendous amount of court data, but a little bit of conviction data. You took public health data. You took the prescription drug monitoring data on the supply. You even took the naloxone administrations from EMS, as well as from law enforcement, separately from law enforcement. Brought that all together and created a picture of where you had hotspots. You could see how people would travel from place to place to go buy their drugs, where those drug overdoses would take place. We even got to the point of being able to take the drug stamp data. So once you did the toxicology analysis of someone who had overdosed, to understand what the drug stamp was, to look for that chemical composition, and if the state police could tie that back to an individual dealer, they would then press murder charges against that dealer if somebody had overdosed. So a really fascinating and dynamic use of data, very complex, but it had a very powerful impact. Now, as you guys know, we've used the term multidisciplinary. There's no doubt that in the opioid epidemic, there are lots of factors. But if you look at New Jersey, over the pandemic, the COVID pandemic, they were the only state in the United States that basically had flat death rate from opioids. Everybody else had increased. They had a flat death rate. They attributed partially, not fully, but partially to this type of analysis and the insights that they got out of that. But again, you can't simply say that was the solution. It was part of the solution. It helped them and the great and the hard work that they did. So just an example of the logical conclusion of where you could take this type of data analysis if the council so chose to do.
I want to emphasize too, on the sensitivity of the data, we can always start with aggregated anonymized data from a lot of these sources. You know, initial decisions that you need to make may be able to be done at population levels. But eventually you may want to continue to work those legislative initiatives, the data sharing agreements, and get down to where we're able to really track, not necessarily that we want to do something at a person level, but be able to track individuals that are in specific programs and what is the long-term trajectory for those individuals, so that you can really begin to assess specifically which people fit best into which programs and achieve the right outcomes. Or maybe you want to get to a person level eventually for coordination of care. So just understand there's a wide range of what can be done as you start a foundational program like this. Jeremy?
Great. I know we're fast coming up on the end of the time, so I'll be very brief here. As we've already kind of covered, here are some four items that we believe will be of value coming out of this. One would be obviously earlier intervention rates. That's primary, earlier intervention rates for folks. And then really that second one is facilitate with our platform cross-agency collaboration, data sharing, or redundancy or elimination of duplicative efforts across multiple agencies. So really facilitating that cross-agency collaboration. And then the last two items are really kind of what we hit a lot on, which is the efficiency in tracking and then the reporting of the outcome. So I don't want to belabor the point. I know there are probably questions and we're running out of time. So with that, I'll just say thank you for allowing us to be here today, for inviting us to be here today. It really is our privilege to be here and really want to partner with you guys.
Thanks, Jeremy. Anybody have any questions? Judge, I'm sorry, Dr. Vanderpool. I saw Judge Sexton first. I promise I won't forget you.
All right, Judge Sexton, go ahead.
Well, no, he's deferred to you, Dr. Vanderpool.
Oh,
so
okay. Well, I just wanted to know, I mean, I think that it makes a compelling case for the utilization of data to be effective and to guide decision-making. My question is, what is the ask of the council?
So the ask would be to fund the proposal that we have in front. I don't know if there's a dollar figure in there. It's 1.48 million, and that's at the high end of the range on that. So the ask would be to fund SAS to software for the consultants to come in and build this, and then we would have that platform out there to host the data in a secure environment. So that would be the ask of the agency or the council.
Dr. Jackson, you have your hand up?
I do. So again, I think we're in the dilemma we were in this morning. And that dilemma being, we need to debate the merits of a proposal, but then we need to discuss whether or not there can be an extra process granting of money or sort of an emergency or outside the grant process RFP request for funding. So again, as a council member, I want a dashboard. I want data. I believe in it. I think that one of the things we need to use this money for is integration of information across platforms. And I think that's a great idea. So what mechanism we fund that by is the question as far as I'm concerned. But also, Mr. Chairman, maybe I'm the dumbest person in the room or online, but I'm struggling to understand the differences. We had a bed board presentation today. We had Helios today, and we've had SAS today. So I'm a little confused. Are these all competing presentations? What is there overlap between these? Because I just want to see one dashboard done well. I don't want to have 3 dashboards or 7 dashboards. So I just like some clarity from you or Mary or somebody about who the players are and what their roles would be, because I need to know that before I make a vote. And then also, I think we have the same issue. I think Judge Sexton will probably bring this up. If we're looking at funding SAS or anybody else, X, Y, or Z, we need to decide if we're going to go through the regular grant process or make this an extrajudicial or extra process funding. So could you and Mary clarify how many players we have on the board and what they want to offer? And then secondly, we need to talk about whether we're going to fund this regularly or with outside the grant process funding.
All right, I'll be glad to. Hopefully I can do it. When I looked at this, they each bring something different to the table. Now a couple of them threw things in that were outside of what I thought was going to be presented and kind of confused the situation a little, but they each bring something different to the table. A predictor of predictions that we're talking about here are not the predictions I was talking about using system dynamics, not the same thing. And so that is the difference with systems dynamics. It's the thing that I haven't seen anybody talk about across the country when I've been in conferences and meeting with folks. Is a way to predict upfront an investment of X amount of dollars is expected to have this outcome on the system that you currently are in. I haven't seen that anywhere else. And that was really what my interest was in that. The thing that SAS brings to the table, you just saw, there's a lot of overlap. The other presentation was I wanted to be more bedboard focused. I don't know if the folks from SAS can do that. Right? We haven't talked about that. These are just 3 separate entities that to me brought all something separate. So one, taking advantage of our current system, because we have a good current system. We have things in place. And for that, a bedboard takes care of that. How do we gauge our dollars that we're investing in expected outcomes? And I think that's what Systems Dynamics does. And then with SAS, pulls all that together in a lot of ways. And so that's the vision that I had in my head. And maybe I didn't do a good job of explaining that. So I've already talked to Jeremy when they walked in was, if something like this happens down the road, could you work with other entities to pull this together? And the answer to that was yes. And I think the answer is still yes, because I'm watching Jeremy shake his head. So that's the vision. Now, what I've gotten from the council today, if I read things correctly, is, an RFP and go through the process. I think that's what I hear. And if I'm hearing wrong, then somebody can correct me.
Mr. Chair.
Yes, sir.
I personally don't see this as the same as grant proposals for services or the grant application. This is administrative.
Yes.
And this is how we come to our decision making from an administrative standpoint, not a merit system on. So I think it can be differentiated.
Okay.
I mean, that's just my thought. I don't know why, but
Well, it was my thought when I asked you to do it. So, but then I was trying to, get the gauge of the room from the opening. And I get, what I presented, how that could definitely muddy waters. And I certainly appreciate the council's wisdom on that. To me, this is administrative.
And I was going to say just real briefly, I mean, I see them working with me, an extension of the Opioid Abatement Council office, like the reports that we're receiving from the counties. I mean, there's only so much that Ella and I can do with that, but we definitely want a dashboard like the other states do, and that would be something that they would help us with. So I see them as a vendor that would work with the Opioid Abatement Council office.
And I know Lisa's got her hand on Lisa in a second. I wanted y'all to know that I revisited with the Attorney General's office an issue we had early on in our council, because we were talking about money that's gotten sent out to the counties, that they can do with what they want on the remediation list. And we wanted that as a council to be a transparent process and say, okay, we gave them this amount of money and here's what they're spending it on, and we put it on our website. And there was some question about whether or not the Attorney General's office needed to okay that, so we didn't take action on it. The Attorney General office did agree with us on that, and they do think that needs to be transparent, and I think that's a good thing. And so I look at this as exactly how Mary looked at it and exactly how you're looking at it. I'm just, it's hard for me to read the mind of the council. That's why I want to discuss it. Lisa.
And I think just some observations that I have about this. I mean, it's obviously a beautiful system. It obviously captures many of the things that we all want to know. The biggest one is, what can we see on the horizon? What can we see happening because of the amount of funds that's been invested with who? But I think another layer of this is, what expectation will there be for the counties to provide data? What expectation will there be for individual applicants to provide data? And what legal assurances, because it was gracious to say that we do own this data, but we only own it if that's been settled up front. And then the degree to which your company owns it, the council owns it, that also needs to be very transparent to the counties, to the individual applicants. If people are going to be expected to provide the kind of data, that this system will only work effectively if you have a very robust data collection system from different kinds of agencies. And I think that needs to be very clearly presented up front, that this is the expectation. If you're getting this money, and give people the opportunity to run it by their own legal counsel as to how much of the data do they own, what does somebody else own, what kind of HIPAA compliant business agreements you have for pass through, what the agency is liable for what they provide to you. That's not a simple issue. And I feel like that could benefit from more discussion about what exactly that means.
Thanks, Lisa. Yeah, it's not straightforward by any stretch of the imagination. I'm sorry, Dr. Vanderpool, and then I'll get you, Armando.
So what I heard Judge Sexton say was there's a difference between, and I agree, there's a difference between funding things that are going to help the council do its job well in terms of reviewing and analyzing and processing data and reviewing applications, and then actually funding quote unquote emergency or time sensitive solution proposals. So it may be appropriate, now may not be the time, but it may be appropriate for us to come up with a criteria for determining if it is not an administrative funding issue that we can make a motion and vote on, but a potential like expedited review like the Narcan or bed board or something along those lines. Should we have criteria that we would evaluate those things against? Using the RFP system that we currently have, some options might be, number one, looking at the timing of realistic implementation from the time of receiving the monies until the solution is implemented. Another thing would be the urgency of the strategy as voted on by the council. Is this something that needs to be implemented within the next 3 months, 6 months, something like that? And then the third will be their score according to the rubric within the predefined RFP that we have on Smart Simple. So I think there may be a parallel path for funding time-sensitive urgent requests within the framework of the parameters that we've already set. But we need as a council to vote on what those parameters are so that we are staying above board, beyond reproach, all of those things, and can justify our rationale for potentially deviating from the more common path for majority of the funding requests.
Thanks, Dr. Vanderpool. Before I get you, Armando, was going to circle back to Lisa's question there a minute ago. Actually, within the grant application process, we've asked grantees or potential grantees to tell us what they're going to measure. I mean, that's part of our scoring. We want to know what your impact is going to be and how you're going to tell us that. And so it'll be what Shane was talking about earlier, part of us learning as we go along and see what that looks like once we have it in place. Armando?
Yes, I had to turn my mic on. Sorry about that. So I guess the question that I have is, it's $1.48 million to build this, and I agree with the integration of information from a wide variety of different agencies in order to have a better idea of what we're looking at. But I guess one concern that I would have would be, is this a one-time expense that we would incur, or would there be reoccurring costs? Would there be reoccurring costs for update and technology changes? Is there going to be costs associated with them in order to become compatible with other agencies? Plus, would this system also be able to benefit us in a way of gathering data from the general public for, when you're putting out this information, when you're putting out Narcan to all these different people with the money that you're putting out, is there a way that they can anonymously put in, that they to help us gather that tough data to get from the individuals that we're not getting from law enforcement agencies or public health officials, but from the general public?
So going to the kind of the ongoing cost, and then I may let some of my colleagues talk about the data collection part. There would be some ongoing maintenance, yearly licensing maintenance, and then since we would be hosting the actual software, there would be yearly maintenance fees to go along with that. But we anticipate that the cost would go down for the initial software. I mean, way down from the initial investment, because you just wouldn't need all of that software to continue to build out the system that you already have. So those costs would come way down, and you wouldn't need our folks to continue to build stuff out. It's just going to be on an as-needed basis. So there would be some ongoing costs. They would not nearly be what that initial investment was.
And Dr. Jackson, and then Tommy, we haven't forgot you. You'll be after Dr. Jackson, Tommy. Go ahead, Clay.
I appreciate Judge Sexton's statement that this seems different in terms of administration than another grant. So there could be a pathway for funding. I agree with you, Judge Sexton, on that. I'm greedy. I want one company, one vendor that will do everything we want to do. I want one dashboard. I don't want a bed dashboard and a SaaS dashboard and a systems dynamics dashboard. I want us to decide on one administrative company to run our IT and to run our data collection and help us with data management and drawing meaning out of data. And I want the bed board to be part of that. So if SAS is proposing to us, then I want them to come to us and say they'll do a bed board for it. Thank you, Timothy, for bringing up and Armando for bringing up the clarification of ongoing costs. It's very important. Secondly, I think before we close business today, Mr. Chairman, we should draw out of SVP a motion for what constitutes an expedited review. So the things that you very passionately presented this morning or whatever, or anybody else that we find in the stack of applications, that Mary and the staff can say, hey, this is a hot one. We need to go ahead and expedite this review to get this money out the door quickly. Because what Shane said about favoritism can torpedo this council, but we want the latitude to get money out the door quickly to something that is time sensitive. So I think Stephanie has presented an excellent way to move things to the top of the stack, but have a reason and a rationale for doing that.
Right.
So those are two things I want to bring up.
All right. Thanks, Dr. Jackson. Tommy?
Hi, guys. if I may, to me, the real issue before we got in, and I agree, the analytics to these systems and all the proposals, the fundamental obstacle comes the data, accessing the data. And I've been doing this a long time, and I happen to be one of those sources for data as well, and collectors of data. So forgive me if I'm not as optimistic at 34 years into this about gaining and migrating all of that data into one system, which I think, and I think everybody, this council and others that know me, know it would be one of the best expenses I think that this program or any program could fund to get all of these. The question is can you get all that data? And I would want some type of commitment before we dove in there and we signed a check that the access to the information necessary for what was needed here or what we're proposing was going to be accomplished.
Thanks, Tommy.
Mr. Chair, do we have a budget? Have we talked about an administrative budget where we can start plugging in figures based on our vendors? I mean, I don't know that we have, or if we have, I've never been part of that. I'm talking about just administrative only.
Oh, like what y'all are gonna spend.
Yeah, not what you presented earlier
Yeah,
today.
right.
We're talking about these collateral services that we're talking about. All right, have we discussed a budget?
So as I sit here and I think about this, we look at our big categories, right? Prevention, education, treatment, and where does this fit? Well, it doesn't fit in any of them, right? And it fits in all of them. And so, yeah, we don't have that. We certainly have the latitude to allocate funds to it, but it's like I said earlier, if we just had a way to get access to what we already have in place without us creating another program, that moves the needle in the state of Tennessee. I think it does. I mean, I think Matt thinks it does. And so that was the whole idea of looking at this in the first place. Maybe I did a bad job of presenting it, but we don't have a percentage of that. And my question is, if you have an RFP for this, because I agree with Clay, we got everything in one place from all these different sources. And I think that's a great idea. But what does that fall under? If you put out an RFP for that, which one is it for? And I don't know that it's for any of them. And I think it's to help the council do its better job using analytics and even predictive analytics. And I don't know what that falls under. Or to take the feedback from the council and let's create it. Yes, General, I'm sorry.
Where do we get the funding for Smart Safe? To me, and maybe I'm lost, but to me, this is much like Smart Safe. It's not anything like
Smart Simple. So Smart Simple, we're not
Yes.
paying for. It's owned by the state of Tennessee. So as an application, we don't pay for it. The customization, we didn't pay for. There was a transaction cost, but it is very low. And at this point, the Department of Mental Health is charged for that. And at this point, they haven't decided to charge us because it was like $20 an application, something like that. So we're not paying anything for Smart Simple.
And when I looked at this journal, I thought the exact same thing you did, the exact same thing, but we're not paying for that. And so it is a little bit different. And there's going to be things, to me, I agree with what Tommy said. I mean, I think this is key to what we do. Because our last word we were given by, General Slater was accountability. And he said, quote, Tennessee is a responsible state financially, and we want to spend our money on things that work. And we're not going to know that unless we're measuring it. And I can tell you, that the councils that I've sat in individual counties, and I've been to several of them just watching because they asked me, when they allocate money, this money that we sent to them, there's no outcome they're looking to affect. They'll take this group of people over here and they all ask for this amount of money and this is the amount of money we have. And so how can we cut this to fit this? And there's nothing wrong with that. None of these things over here are bad. But my question to them at the end was, how do you know that the $380,000 you spent just now is going to be effectively spent in the next year? And the answer is you won't. You won't know. And I'm not mad at it. I'm just trying to get them to see that. So that was the reason to bring this here is to look at this. And if you've got multiple dashboards, I agree with Clay, I don't want that. But each of these people bring a little bit something different. And they've got to be able to work together. And I can't do that. I'm not a computer guy. I have no idea. And that's why I want them to meet each other. But I thought this fit in with Smart Simple. Wayne.
Question for you guys. Data acquisition. It's going to run your whole show, isn't it? So what do you know about that? What have you found out? in preparation for that.
Well, do you want to talk about that from North Carolina?
Yeah, so to give you a little bit more on my background, I established and ran the Government Data Analytics Center in the state of North Carolina and faced similar challenges to this. The thing that sort of started that initiative was a criminal justice project where we had 2 university students who were murdered at University of North Carolina and Duke within weeks of each other. And it highlighted that we were not sharing sensitive criminal justice data, and therefore decisions were being made without full information. And had the full information been available, potentially those murders could have been prevented. Both individuals should have been in custody at the time the murders took place. We faced the very same challenges. At the beginning, every stakeholder that we brought to the table to build an integrated criminal justice system said, cannot share this data. It's CJIS qualified, it's PII, it's, you know, it's even education data, it's FERPA related. And what we had to do was we had to start with the data sources that we could get, the ones that were most readily available. And as we began to put those data sources together and show the results of being able to work off those data sources, we were able to work with our legislative partners to get authority to get additional data sources. But we also began to work with the legal counsel from those organizations to say, look at how we're managing and handling this data from a governance perspective. And we began to be able to work within the protocols that they had for sharing their data and prove that we could technically control it the way they wanted us to control it. Over time, we would add in additional information. I mean, we added in information, for example, from driver's license information, which is tightly controlled both at the federal level, but in North Carolina, even more tightly controlled at the state level. But because we could explain the justification and the reason for using the data and how we were going to use it behind the scenes for analysis, but not expose the data to anyone, that's what allowed us to be able to begin to build that. And over the last 12 years, this program in North Carolina has moved into all sorts of health information, mental health data, revenue information, federal tax data. So it is a process and it is a culture change, but we have state partners where we have been able to do this, and it's a gradual growth change.
Okay, I got this job on a Thursday night, and Friday morning I called Rob because I knew Data had to be a part of it, and he said, "Steve, you got to go. Where'd you send me, Rob?"
No, I don't remember specifically, but
Just me to North Carolina.
oh yeah, absolutely. Yeah, that's right.
And Rob sent me immediately to North Carolina, so I went and I looked at that immediately, and loved what I saw. There was all kinds of, so it's not going to just happen. There's going to be an incremental, stepwise process, which I don't understand, but I know it has to happen. But we got to get started somewhere, though, right?
That's right. And, I think that as you begin to show your stakeholders what the impact of using the data is, it will be slow, but minds will change. And so you start with what you have. And again, we start with anonymized, aggregated data that they may be able to release. I also do want to go back to the whole idea of ownership. In our mind, this data is never our data. All of our contract relationships say we are using customer-owned data. So never will you pay SAS for us to give the data back to the state. Never will we say we can use this data for any other state's purposes or for any purpose other than what this council says. We are very, very strict and rigid about the use of the data that you provide for your solution.
So, Dr. Fournette, I'm sorry.
Yeah, is the state human services currently looking at data analytics incorporate or have one themselves?
I'm sorry, Dr. Fournette, you broke up and we heard about every third word.
Does Health and Human Services state of Tennessee currently have data analytics they utilize?
So the Tennessee Department of Human Services, we do not have a footprint there right now, but we are talking to them. I mean, we've been talking about potential SNAP TANF, looking at, to Sean's earlier point, looking at fraud analytics in there. So that's one of the few agencies that we don't have a footprint at right now. But we're in other departments of humans, like our sister state of Georgia, huge success story down there in Georgia with SNAP TANF benefits. So we have, even though we're not doing it in Tennessee, we have a lot of experience in doing that in a sister state, neighbor state.
And to give you an idea, in the state of North Carolina, we run the health information exchange for the state of North Carolina. So, I mean, there's a good example of HIPAA, very, very comprehensive HIPAA data that we manage.
So what's our path forward right now with regards to what we just had presented here? I think everybody, if I gauge the room right, then we all feel like this is an administrative cost that helps us do our job as a council. I look around, I see nodding heads, so I think that's the case. I don't think anybody's comfortable with funding it today, and that's fine as well. So what is our path forward? I think what Clay verbalized is what we've all been thinking probably deep inside. We need one source, right? We got multiple things out here. How do we, and so, do these people need to work together to get us this one source? Is it in the form of a short turnaround RFP that we can review as a council? I mean, that's just the idea that I had. It is one of the things I asked early this morning outside of the first and the last was a short turnaround RFP, a 45-day RFP. We put it out 45 days later, you've got a proposal and we're going to look at those proposals and make our decision. And that was the thought process. So those are my ideas. I don't know if anybody else has anything, or we need to go a different direction, or do we lump it in with every other grant request out there? My fear about doing that is if you're sitting there and you're reviewing these grants and you look at prevention, education, and treatment, you're a grant reviewer. This doesn't fit in any of them, not a one. And so I think that presents a huge challenge on our grant reviewers, and I think we're going to miss the boat there.
If I can offer one observation, again, going back to Dr. Jackson's comment about one platform, one dashboard with multiple components of it. By virtue of being on statewide contract, one of the benefits that we have to that is not only do we have all of our software and services and everything on there, we also have the ability to kind of subcontract out work to other folks. So if it was the council's desire to do something and we worked with other entities, whether it's the System Dynamics or other groups along those lines, we have that ability to work with them, let them do work in the SaaS system so that we do, to your point, Dr. Jackson, we've got one cohesive, comprehensive platform dashboard that may have multiple and should have multiple components to it, but it's one platform to do it all.
I understand.
This is a little awkward because I'd love to talk to my council members and fellow colleagues here about the 3 or 4 entities we've had proposed today and what the advantages and disadvantages are with you out of the room. But I can't because Tennessee's a sunshine state and I'm not allowed to smoke my cigar without you knowing. I can't talk about you without you being able to sign on to the meeting and hear what I'm saying. So I'll just say the quiet part out loud. I like what SAS has proposed today. I trust their experience. I trust they've got enterprise level experience in this area, in this space. And also SAS has done this in other states. They have the state contract. They're here. It's not new. It's kind of like using Smart Simple for free. We're paying for this, but Smart Simple was already set up. So I like that. But I just want to tell you, SAS, I want you doing the bed board. If I vote for you, if we fund you, I want you to add a bed dashboard to that. I don't want you to just take New Jersey's solution and slap it onto Tennessee. I want you to listen to us and what we want. And there's 14 other members. They may want other things too, but I can tell you, we're all going to want that bed board as to be part of whatever dashboard you build for us. Can you do that?
Can I speak to that? So yes, absolutely can. So we have a whole organization that is our advanced analytics lab that is comprised of many, many data scientists. And to partner with that is the team of my team as well as Sean's team. To give you an idea of the team that I lead, I have a team of 33 industry consultants. Every person on my team came out of state government. I have an epidemiologist, a pharmacist. We've got people who are experts in public health policy and Medicaid, operation services and clinical analysis. So yes, we have the resources to be able to do that work.
Mr. Chairman, I think we're over time or approaching that time. I would say that we need 2 motions here. I'd like to see Stephanie put forward a motion about expedited review on routine grant proposals. And then I've got a motion that I'd like to propose about how we handle this administrative fee and what we need to do here, because I think we should offer each of these entities an opportunity over about 2 weeks make us a proposal. I mean, 1.48 for building it is fine. To Armando's point, I want to know what the downstream costs are over the next 3 years at least. So I see Timothy shaking his head, and then SAS has proposed what they would build, but then we threw this bedboard on them. They deserve an opportunity to come back and say, that's going to cost you an extra $50 or 50 million, whatever they say it's going to cost. So before we close today, I think we need those two motions on up or down vote on what expedited review is on regular grants, if we want to do that. And secondly, maybe give folks like 2 weeks and then we have another emergency meeting to vote on this, because I don't want to wait another quarter to vote on this administrative thing.
Okay, so I hear you, Clay. So we'll start with you.
Oh, thank you.
Oh, I'm sorry. I did not see. I don't know how I can miss Tommy's head because it's taking up the whole screen. Tommy, I forgot. I forgot you. And you look like the Terminator. So go ahead, Tommy.
No, listen, I'm all about this, and we've had a lot of things that we've been talking about. I would just encourage us to talk to the Department of Health first. I mean, there are analytics, there are many programs out there that are doing a lot of this material. We're just doing it in our own silo. And so having a discussion from the Department of Health that says, hey, can you accomplish this? I know they have a whole division of informatics and analytics that are over there. I think the hurdle or the obstacle that we've had is just we've not been able to overcome the sharing hurdle. And so I'm not sure what SAS can do that we can't do together to overcome that. But at least if it is a financial or a funding issue and it's an administrative cost, let's talk to the Department of Health. Let's talk to the Department of Mental Health and see what we can accomplish within. And then if we can't overcome those, then I'm all about getting the information that we need pulled together.
Well, in the 2 week time frame, Mary and Stephen could circle around the DOH and Department of Mental Health, and they could tell us, Tommy, what we can do on the state side that we already have, and then SAS and anybody else who wants to play ball could tell us what they can do and what the real cost is going to be. Then we can compare apples to apples and oranges to oranges.
Dr. Vanderpool, sorry, you're not on my big screen. You're on the laptop, but I see you now. Go ahead.
No worries. I think, well, I think what Clay mentioned and Tommy mentioned has good merit. The other thing I'd like to raise is that if there is a way to potentially incorporate some of these other folks who have proposed today, maybe SAS does not have to build a bedboard from scratch, since there's already companies that have already built it, but maybe they can find a way to work together. That's just something I wanted to throw out there. The second thing is that I do think we should have a process for expedited review of proposals. However, I do think there should be some very clear criteria that the council should vote on as to what qualifies for expedited review. The first and most foremost should be, are they going to be able to stand up the project within X number of days of receiving the funds? Because some of these projects, they ask for funds and they don't actually expect to touch the first patient or see the first outcome until 60, 90 days from when the funds are received. And in that case, that does not warrant expedited review, in my opinion. So that would be the first criteria. The second would be, it's a little bit more nebulous. How does the council view in terms of the degree of urgency? What is the council's view on whether or not this thing counts as an urgent action or not, i.e. whether or not we think that naloxone distribution to everybody within the next 60 days is going to be considered urgent? That would be up to the vote of the council, but I think that would be required. And then the third thing I would say is whether or not their score within the rubric that we've already put in is greater than 85%, because we don't want to fund things that are urgent and can distribute things within a timely fashion. But then if we look at the merits of it overall, it's a 60 or a 70 or something like that. That's not considered a solid overall program. So those would be my recommendations.
Okay, thanks, Dr. Vanderpool. All right. Did you decipher all that?
Well, I mean, I've got the numbers or what Stephanie was thinking for the expedited review, but I think what I'm needing are, I've heard several ideas for next steps, reaching out to the other departments, different things like that. But if I could get those, like, clearly, what outcome do you guys expect?
Yeah, and I want to clarify that. Stephanie, I've got those. We'll address those in a second. I think those are really good to start with. You know, when reaching out to the other departments, I mean, what do we ask them? I mean, I'm not even sure what data we need, and I'm not even sure how to ask the question. I mean, I'll be glad to. I don't know what SAS knows. I don't know what the other folks know, in order to talk with them to see if we already have access to that data in another format somewhere.
And I think the other component to this, and I'm just thinking from an operations point of view, that's what my role is while the other departments may have access to information, I don't have staff to manage that. So I didn't ask you guys for data people, data analysts, business analysts, under the kind of, Steve and I had been talking about what this might look like for the Opioid Abatement Council. And we had, was thinking more along the vendor route. So if we don't go the vendor route, then I will need to come back and ask for data analysts, stat analysts, people that can compile that information. Yes, Lisa.
I have one just an observation. Would it be a good start to start with Department of Mental Health and Substance Abuse and say, if you all routinely run reports, which they do. They run reports on the different grant programs they have in their data system, TN.gov. If the department would give access to Smart Simple within their data system, TN.gov, to reports ran, not actual client information, and if so, what would that process look like? Because I think it would be a good place to start with the department that's housing the council to say, what would it look like for this group to obtain your data on just reports? And that could be a good start point.
And we can ask them that. There is something I'd have to go back to Sam about state dollars being spent on Opioid Abatement Council processes, different things like that. I mean, it's still like how many staff is within the office of, I don't know what it's called, informatics at the Department of Mental Health. Do they have enough staff? I'd still need to get approval from you guys to pay for this.
So each department would likely have to do that exact same process.
Yes. And so, but right, I can go back and talk with the data and informatics section at the Department of Mental Health, find out what their bandwidth is, and or do they have the capabilities to pull information out of Smart Simple, do the compilation of the reports. Is that what you're asking?
No, what I'm asking is if TN.gov is the system, Steve's real familiar with it, with Department of Mental Health and Substance Abuse. That's their data collection system.
But we're not planning to use TN.gov for the proposer, for the
right.
grant.
She's talking about giving access.
TN.gov runs reports on how many people have entered inpatient treatment this
Okay,
month.
so this would be more the what's happening in the state, not compiling our data.
No, it would be if Department of Mental Health and Substance Abuse, they run periodic reports, whether it's for federal block grants, whether it's for a variety of reasons. And if, for example, you were wanting to know how many pregnant substance abuse or substance dependent women have entered into treatment in the state of Tennessee in a state funded program this month, they can find that out real quick. That's their internal data collection system. So I think it would be interesting for council members to know, what would it even look like for that department to share that data with SAS? What would that process look like? Because if that could happen fairly easily, I don't think it's a far jump to say, wow, they could do that with Department of Health. They could do that with Department of Children's Services. They could do that with the other internal state departments. But if it is a very laborious process, even with the department who is housing us, I just think that gives council members a little bit of something to go on, because right now we don't know what that process would look like.
Yeah, we don't. And that's when we're thinking about this. These are all questions that come up. I was like, who owns this? Are they going to share it? I mean, Jeremy, and then we'll tell you, I asked him that. numerous times because I don't understand that. And with that said, I don't think that there's a direct pathway for us to take action on the administrative of these two proposals right now until we know that stuff, right? We have to know that.
But that could be a good starting.
It could be. And I think that, I could work with the folks and have these conversations. Obviously, I got Matt sitting here right beside of me, and I know Matt knows his counterpart at health that we can talk to, and then anybody else, because as you all know, this touches everything. It touches DCS, it touches DOC. So go ahead, Matt.
When I think about data, I think about, output data versus outcome data. I'm here as chair really focusing on outcome data, which is, that's the gold standard. I think about, you raise a good idea, but I'm also thinking about the grants that the council will fund. And, we work with, probably 300 different organizations across the state, some of which are in this room, but it may very well be the council is funding people that we don't have a relationship with, and that's great. But I think focusing on, collecting data among your grantees as a council, that's where I would really focus in on. And then thinking more about just, how many people did the abatement funds put into intensive outpatient treatment, how many in residential, how many, whatever. That's one thing, but what happened 60 days, 90 days, 6 months, a year after the fact? I think some of our systems can account for that. Some of that data is really hard to come by. As you all know, I've seen a lot of heads nod. So I would just caution the council as far as thinking about trying to utilize systems that we have, because in some ways it may not be what you're looking for.
It's not going to be complete, but it'll be a part of it.
Right.
And I think that, state data is vast, and I think SAS having access to state data that helps us with these decisions. I think there's a benefit to that. And right now we don't even know what they would be willing to share.
And on the bed board matching, I think that's a great idea. And I think Brian brought up what's happening on the inpatient psych side with the HERT system with DOH. The challenge there, and Karen referenced this, is how do you get the hospitals to maintain their bed availability, not once a week, not once a day, but like hourly? And how do you incent that to happen? But that may be another system, and it's run by health, and it may have relevancy to what you're looking to do related to substance use treatment and bed availability, because that system's there.
Yeah, it's called Find Help now. You're not familiar with
Oh, no, and I knew it existed, but I didn't know that's what it's called. And when I look at, I get that, and I've got that from multiple people that I've run this idea by. The first thing, it's the right thing to do. It's hard for me to stray from the fact that, we're going to have 3,000 people die in our state, by next summer. And you're going to give me a pushback that, it's too hard for us. So I always prefer the carrot approach and have a reward in there. But I'm not opposed to the stick, because we got the same pushback with the CSMD. And I haven't heard a word raised about the CSMD in a decade now. It was going to be too onerous on us. It was going to be this, it was going to be that. I haven't heard anybody complain about that forever. So I think there's multiple routes to go, and I don't want that to impede us. I'm trying right now, as quickly as I can, to figure out a path forward here and the actions that we need to take before we can go. And from the administrative side of the house, what I'm hearing is that we want everything on in one space. And if that's SAS getting other people to help them with the things that we want, we'll leave that up to them. Okay, I don't think we can make that decision for them. The other thing is that that we want to know what we have available that SAS is going to have access to from the different departments that we're going to want data from as part of our data set. Is that correct? Okay, if that's the correct, then there's no action for us to take other than SAS to figure this stuff out with the help of Mary and I, and then come back to this council.
Yes, sir, Mr. Chairman, but I'm requesting that we have a meeting in between cycles so that we don't have to wait another 90 days to act. Just because we can't act today, we shouldn't wait till January.
No, I agree. And that's one thing we did establish is I do have the authority to call a meeting anytime that we like. So we can definitely do that. Okay? So if that's okay, then I'll get with Mary and I will get with the folks that we've had today, and we'll figure out what that looks like. As soon as we have something ready to bring back to you, then we can, we'll have a called meeting that hopefully everybody can join by remotely. Is everybody good with that? Okay. So that takes care of that side of it. Now for the expedited review, Stephanie laid out 3 criteria for this. And I'll tell you what they are. One was, are they going to be able to stand this up in blank number of days? For me, expedited, 4 weeks, within a month. I mean, if you can't do it within a month, then how emergent is it? And
30 days.
Yeah, 30 days. So that's my thought on that. Next is, what is the council's view on the degree of urgency? And I don't know that we can do that outside of, we want to bring this up, and here's the reason why. And the council leader says, yes, I agree with that, because I don't think anybody in this room is in opposition to us doing something right now to address this. I mean, I didn't see it. I think what I saw from the council was, we want to be very careful with the process so that we don't set precedent and we don't have to take blowback from things that, because we acted hastily. Is that right? Okay. So that would be a discussion for the council. And then Stephanie's last one would be a pretty easy one. They fill out the grant application. If their score is below 85%, then they don't even get to us. And that seems pretty reasonable and pretty straightforward to me. So if we would like that, I would need a motion to do that, to entertain that, and then we could move forward with an expedited review process.
I move that the OAC institute a policy of potential expedited review for any grant proposal that the council members and/or OAC staff deem to meet the following 3 criteria. The proposal is of an urgent nature in the opinion of the council. 2, the proposing agency represents that they can engage patients and clients within 30 days. Number 3, their overall grant score is 85% or greater.
Got it. All right, I've got a motion on the floor as stated. Do I have a second?
Second, Moore.
Okay, I got a second from Mayor Moore. Is there any further discussion on this?
Stephanie, did I do your motion the way you wanted?
Yes, thank you. Sorry, I wasn't able to jump on at that moment. But those were the 3 points. Is there any discussion on the motion?
That's what we're talking about right now, Dr. Vanderpool. The floor is open for discussion.
Mr. Chair.
Yes, sir.
How does that particular grant get in that line? It's selected by us. We say, this is a hot button, Narcan. It's hot button. We want to get at it. Here's a proposal for that. It's 15th on the list of people to apply. Do we grab it and pull it up? Is that what we're talking about doing?
Great point. And I think, yes, it is what we as a council, or any council member, not just me. I mean, there's 15 of us. Actually, I was talking to Casey right out here at the interim. If we've got something that we feel like is a hot button, then these are the criteria it's going to have to meet. And somebody from the council is going to have to stand up, just like I did this morning, and tell us why it meets this. So I think it's something that we grab, and it gives us the flexibility to act quickly if we need to, if we feel as a council. And if we don't, there's 15 of us. It'll take 8 of us to say that it is or isn't.
Should that language be in the motion in some way?
Clay, would you entertain that friendly amendment? It sounds like one.
Certainly not.
I entertain a friendly amendment. Tell me what you want to say, Shane.
Just something to the effect that these proposals are selected by nomination or by some way within the council to get it from that positioning where it came in. For instance,
Okay. So, Mary, keep the motion as is, and then append this sentence to the end, please. Such proposals would be nominated for expedited review by any OAC council member or member of OAC staff.
Thank you, Clay. Is that acceptable language? I started to call you Dr. Sexton. So, all right.
I guess a question that, would there be a way to identify other like proposals that would meet the same need that have, I guess, either currently been submitted or would we want to seek proposals to meet that need that we're expediting?
Right, if there's something else, somebody else is
So I think
gonna.
what he's
I
saying
think we
is-
depend on staff for that. I think we depend on staff for that. And we might have 2 proposals that are expedited in the same area. But I think we depend on staff. If I raise my hand and say, this is a hot one, Mary, we need to move this to the top of the pile, then Mary might say, Elizabeth told me we've got another one like that. Let's look at both of those together at the next meeting.
Because I was just gonna say, harm reduction is one of our categories.
Uh-huh.
So again, we're talking about Narcan, or
Right.
maybe some other proposals that get put in there. So I definitely think we're gonna have to be very careful.
No, I think we gotta be very careful with everything we do, which is why I rely on the knowledge of the council. So I agree. And I do think that Clay's suggestion is a good one, that staff would identify those other proposals and they could bring it to us, and maybe Mary and I could screen them. And if we have any questions at all, then we bring it back to the full council, or maybe may just err on the side of caution and bring them all. But I do like that we've got a process, and there's criteria here that we've had to meet, and then how we will go about plugging them. And then we will just rely on our staff to present any light proposals that had already been presented. Oh, I was going to.
There they are.
I at least had that one, Sam. I knew that. All right, if there's no further discussion, we'll do.
Dr. Lloyd, are we opening Pandora's box here for any vendor to come to one member of this council and to say, hey, I've got this great proposal, will you bring it up as an emergency? And, you know, what happens there? And I'm just a little concerned that we're about to set ourselves up for a whole lot of criticism and to be examined very closely when we start calling everything an emergency. Because to me, what we are doing is an emergency. Everything
Not
we're
an emergency. Not an emergency. This is expedited review.
But what's our justification for expediting one over the other unless there's an emergency of some sort?
That is determined by the council. Obviously, everything, as you said, everything that we deal with is an emergency. It's urgent. Steve's already told us he'd declare a public health emergency if he had the authority to do it. But I think if somebody comes to me or you or anybody else and says, this needs to be expedited, we're all going to have to vote on whether it's going to be expedited review. And that all these proposals are still going to have to go through the same rubric. It's still a level playing field. They just got to be measured ahead of somebody else in line. But we're sitting on $90 million. It's just a question of when they get the funding. If they deserve to get the funding, they're going to get it. It's not like we've got 9 million and we're going to run out and the 10th person to apply for $1 million is not going to have it. This is just a question of how soon we go through those 400 applications we have, and can we move maybe the harm reduction stuff up first? This is just a mechanism for how we sort the files that we got. We're still going to get to application 387, and we're still going to have money at the end of the line.
And Joe, I think that anything that we do opens Pandora's box. I as well look at all of it. So yeah, I do think we're opening it. And I do think that we're opening ourselves to people to come to us and say, hey, this is urgent and we need it expedited. But I would, do like I did this morning, and which is rely on the knowledge and experience of the group. And so I get your concern. Yes.
I have another just question. Even if we come up with a process that we all agree upon that provides a good, clear mechanism for a proposal to be expedited and reviewed, is it correct to state that that project will still have to go through, and I keep pointing at Matt, the project will still have to go through the contracting phase with the state of Tennessee and have a signed, executed contract before they can begin any work within the scope that they then can submit an invoice for the first quarter's payment against? So we can
My
I
motion,
mean,
my
you
motion
would-
doesn't cover any of that.
Right, so really, it might be a good consideration to have an expedited contracting process. If, as we go through and score these, we're like, hey, this needs to be at the top of the contracting pile. Because if we fund 400 projects and you're number one in line to have your contract go through the state system, and you're number 300, that's going to be a big gap. So I would even put that out for consideration, that we could be looking at opening a Pandora's box of people approaching council members, approaching other people to have their ideas put out front. We go through this process only for them to be in the contract line and to say you can stand something up in 30 days. You may be able to stand something up in 30 days, but if you don't have if you don't have a contract scope that you start work on January 1st, I could be approved today, but my time of standing it up starts when the scope of the contract starts. So I would just put it in the backdrop of those things as well.
Are you offering that as a friendly amendment to my motion that the 30-day criterion would be from the date of a completed contract?
I would put it 30 days from the beginning of the scope of the completed contract. And I also would offer, as a very, very friendly amendment, that we might be well served to consider an emergency or an expedited scoring of where they fall in the order of when their contracts are going to be pushed out. And that there are some projects that would be on the front end of working their way through the contracting process rather than at number 300. Just thought.
Yeah, Judge.
This is the very reason why we should be judicious about this expedited process. I mean, these very questions, what's the paperwork look like? What's the time of? I can't see this happening a lot. And it shouldn't happen a lot, because then nothing is, it's nothing's fast. So the framework is good, I think. We'll learn from what we come across, and we can play around with that. But can you call the question again? What is the motion again?
I've got the motion written down here.
What is the
I'll be glad to.
73?
Well, I think I lost track when we got into contracting. I did the best I could in writing it down, but it's for an expedited review that it would meet, State Stephanie's expedited reviews. The timing of realistic implementation from the time of receiving monies to implementing the strategy. We had that as 30 days. Urgency of the strategy is voted on by the council, and a scoring using our rubric of greater than or equal to 85%. And I think that's it. And as I sit here and listen to this, I get all kinds of angst and anxiety.
Well, but that is a path.
It is a path.
It's the start of what we're talking about.
It is.
Whether or not the NARCAD thing would have worked, it might have got through that if we had the process together. I don't know.
Well, it's what I told you. There's no way to do this outside of discussing in this meeting. I couldn't come to,
No,
we couldn't do it, right?
I mean, no criticism of that. I'm saying that this is why we should rarely use this process.
The only reason for this is that we have, in my mind, and I'm not the governor and I'm not a public health guy, we have a public health crisis right now in Tennessee. We do. And this is a way to keep X number of people alive until we can get programs funded that are going to help them. And that's just the way it is. And that's how I saw it. And that's how come I put it together. And it's why I brought it before you. And the council wants to take a direction of being deliberate, which I completely understand and I get. I don't have my feelings hurt. This should be really rare. I shouldn't see this happening again. But I think General Flynn's right. I think it will happen again. And I think people will see this and they'll listen to it and they'll say, well, there's a pathway. So if I can get to Mike Flynn and get him to bring this up. So I do think that is a possibility. However, I also trust the brain power of the group. I trust just like I do right now. And so this was just a stopgap measure, because next summer, Mary and I are going to go before government ops. And there's gonna be somebody up there that's gonna raise their hand and they're gonna look at our expenditures over here and all of them are gonna be on administration. And they're gonna, what have you all been doing? You haven't put any money into the community. Well, we've got the grant process and what have you done? And our answer there is gonna be, we've followed our process, and that's okay. So I kind of look at it from that standpoint. We're gonna have to defend our actions and what we have in our community right now. And what this council knows is that we've got, about 9 Tennesseans dying a day right now. So that was the whole reason for it. Maybe I should have just not brought it up at all. But if I hadn't, we would have never been able to start to hammer through this process.
That's certainly not what I'm saying. And I think that there's not one bigger problem in the drug world than Narcan. I mean, that's very clear during the presentation. That's a hot button. Now, we're the ones that ought to decide what the hot button is.
Yes.
If somebody says, oh, we've got, this rash of blank over in blank, I mean, we can't necessarily call that a hot button. Or this one is a hot button.
It is.
And now we have a process to get to it. So.
I thought everybody in the room this morning agrees this is an issue, right? I didn't have anybody going, oh, this is nothing, right? Nobody. And so now, it's painstaking, but we do have to get the process. And I don't know how to address General Flynn's concern because I do think it's opening Pandora's box. My point would be, I still trust this council. And if Casey brings us something out there that somebody's got to him with, I think Casey's he's gonna have to really have in his mind that he feels that way or he wouldn't bring it before us. I mean, I just trust that. And the truth is, if we get anybody reaching out to us, we actually should be funneling them to Mary anyway. I mean, it happens to me almost on a daily basis, and the easiest thing to take it off my plate, send them to Mary. I'm sorry, but that's the way we got it set up. So if General Flynn gets somebody that calls him and says, hey, this needs to be an urgent, says, I'm not sure about that, but we've got a process, and part of that process is me referring you to our administrative folks and giving them Mary's email and the website, which is what we've routinely done, and I can't tell you how many times a day we do it. So I do trust that. So if we want to move forward on this, that's the motion as it stands right now. It's been seconded. Unless we have any further discussion, we can do a roll call vote and then we can move on. That's okay. All right. So I've got I can remember everybody. We're going to start. So a yay is you're in favor of the motion, and nay is that you're opposed to it. Armando?
Is Armando still on?
I don't know.
Is Armando still on?
Okay, Armando is not on. Brian?
Yay.
Sheriff Cox?
Yay.
General Allen?
No.
Dr. Jackson?
Yay.
Karen Pershing?
Yes.
Mayor Moore?
Yes.
Lisa Tipton?
Yes.
Judge Sexton?
Yes.
General Flynn?
No.
Dr. Vanderpool? Well, we can't hear you, Dr. Vanderpool, if you said anything.
She's on mute.
Yeah. All right, I'll circle back to Dr. Vanderpool. Me, I don't vote. Dr. Fournette?
No.
Okay. I abstained. Tommy?
No.
Okay. And Wayne Wyckoff?
Yes.
Okay, so Dr. Vanderpool, are you back available yet? She stepped away.
Stephanie, are you on? I am not seeing her. Oh, she's right there.
Yeah. Yeah, hang on a second. We'll reach Stephanie.
I'm sorry, guys, I missed that last bit. Can you repeat, please?
No, Stephanie, we were just taking the vote. The yay was in support of the expedited review process as presented, and the nay was against it, and we're just waiting on your vote, and it's a roll call vote.
Yes. Yay.
All right, so the motion will carry 9-4. All right. And we've got a plan on administrative.
Yeah.
All right. Okay, well, are we gonna, is Carrie gonna go?
No.
Okay, yeah, it's been a long meeting, guys, and I feel like it's my fault. I feel like I let y'all down. Do we have any public comment?
I have two comments. One was just an idea for your consideration about the potential to maybe push money into the ROPS that are already in 46 counties, and have them expand their services. If you want to do that urgently, it's just an idea. Might solve a little bit of consternation here. And you might be able to also include Lyle's group from Meharry as agents for that. It's a subcontract. The other one is related to data sharing agreements. And I just sent Mary and Steve an email suggesting that maybe the AG's office could help facilitate that. I'm not sure about that, but it seemed like we have a connection to the AG's office, and we have a connection to all kinds of other legal resources here. So maybe there's a path forward there that could expedite data sharing. I don't know. There may be a reason not to do that. The third thing is, I have a question about, is this time for a question?
Yeah, absolutely.
Okay. I have a question about being a state agency that might apply for funding and whether or not there's a cap on indirect costs.
The Opioid Abatement Council did not address indirect costs. So there's no guidance on indirect costs.
That's what I thought. Yeah. Our institution, well, okay. We have a way of doing business with the state historically that is about 15% indirects, but our institution is looking at indirects as if it's a regular federal grant. So there's some concern there.
Thanks, Rob.
Yeah.
Those of you that you've used the acronym, it's Regional Opioid Prevention Specialist. The state already has them in place. A lot of the work that we talked about today, they do a great job with all across the state.
We do not have any hands raised virtually.
No raised hands virtually. Anybody else here in person have any comments?
I do.
Yes, please.
Angela Heckman, East
Hey, Angela.
Director with Rob. This is just a quick comment that's come to me recently as we're organizing our proposals, and perhaps this is not the right venue, but I wasn't sure what the right venue was. Your RFP has paragraphs, say, for example, it says innovation is the first paragraph, and then it's 300-word max, or so impact is the first 300-word max. And then you have subcategories under it that are asking folks to respond in certain ways to those subcategories. Within the portal, those subcategories are not matching what's in the RFP, and they're separated by word counts. So if someone's writing a 300-word response to impact, and then they're going into the portal and they've prepared everything and they wait to the last minute, those segregated word counts across your subcategories are not clarified in the RFP, and folks are really running into some problems with that. And for institutions that may be submitting multiple proposals, that's going to be particularly problematic on the office that's trying to plug in the data from the principal investigators. So that just came to me today, and I'm not quite sure how to answer that, and a lot of people are asking me questions. Okay, I'll go back and look at it. Okay, thank you.
Anyone else? All right, our next council meeting, we should need to make hopefully. Oh, I'm sorry.
Jeffrey Nate.
Jeffrey, yeah, it's Dr. Nagy, I think. Yes.
Yeah, thank you. Yeah, thank you. So just in all transparency, sharing data to expedite, one of the things that has worked for addiction abatement has been setting up significant research studies. You all have a great research institution at UT. So that way has expedited when we've needed data. That is a way to expedite data sharing, is having the research institution kind of take the lead on some research and then establishing, already have established contacts. So that's the freebie for the day. Thank you all.
All right, thanks, Dr. Nagy. Anybody else? All right, we need to decide on our next meeting. We need everybody in person at our next meeting, and we have at least one council member that can't travel.
So if it's okay with the council, even though it's still in East Tennessee, I'd like to suggest Knoxville for our next meeting so we can have everybody present. Is that okay? Anybody opposed? Clay, you okay with that? Clay's got to come the furthest. Even if he's not okay with it, he's outvoted, I think. So
I was gonna be here. I was gonna be here today. You know, my flight got canceled because American Airlines can't fix the brakes on their plane.
I do. I told everybody that before you came on, Dr. Jackson. I promise you. So
I was furious with American Airlines. My wife was delighted, not because she loves me so much, but because we have 3 kids under 5 and she needed an extra babysitter.
Absolutely. Well, I'm glad she got some help. So our next meeting, and we'll send out a poll of when we can have it. We'll go ahead and schedule it for Knoxville before the end of the year. So does anybody have a burning desire? Thanks for your patience. I know it was long and arduous and I greatly appreciate it. We stand adjourned.